The live stream's up.
Okay, thank you, Enrique. Deepti, I can edit that event real fast if
Okay.
you're not, or if you haven't already done it. Okay.
I haven't done it already. I just logged in. Go ahead,
Okay.
do it then.
That worked, Tim. Okay, that link is in the Eventbrite. And so we're going to get started in just a second. I'd like to thank all our attendees for being here. Okay, everybody, it's the hour. Let's get started. Thank you very much for coming to VentCon 2020, an open source ventilator conference. The theme of this conference is Towards Cooperation in the Pandemic Midgame. This is hosted by Public Invention, Helpful Engineering, and Make Magazine, with special thanks to Deepti, Avinash, and Enrique for helping us out in hosting this conference. Public Invention is a U.S. charity. It's a 501c3 charity. Tim, is Helpful Engineering a 501c3 yet? I think you've applied for it, maybe. Okay. The reason we're here is that the pandemic has killed 328,000 people worldwide as of this morning. Thousands of people right now are trying to save lives by preventing a shortfall of invasive and non-invasive ventilators. This conference is to support and bring us together as a community to save lives. The mechanism we are specifically exploring is building open source ventilators, which may lead to longer term development. COVID-19 is a great creator of chaos and confusion. I hope you guys will be patient with us if we make some mistakes in running this conference. We have a code of conduct. You can find it on the Public Invention website page for this. If someone misbehaves, please contact Deepti Sharma at that email address. Additionally, we have Slack channels at Helpful Engineering, and we have quite a few topical Slack channels set up, which begin with the prefix sharp VentCon 2020. We recommend that you join that and try to talk amongst yourselves. One of the nice things about a conference is getting to meet people interested in the same thing you're interested in. If it weren't for you guys participating, we could have just made this a series of lectures, but it's better to create a sense of teamwork by having people work together. So we hope there'll be a lot of conversations created in Slack, and people will maybe meet people they didn't know before this conference. So I'm going to be keeping time pretty strictly so that people can leave and come back for a session if they want to see a particular session. However, we hope that you'll stay for the whole conference. We've got a really killer set of speakers that I think you'll enjoy. We hope to produce videos that will be edited after the fact for this. In the unlikely event that we get more people than can fit in this webinar, which seems unlikely at the moment, we do have it live streamed at YouTube. So the program for your planning purposes for the next 3.5 hours is this introduction, which we're in the middle of right now. And then we're going to talk about the landscape of the ventilator problem and modularization. And that's going to be Tim Arts, who is with Helpful Engineering, and myself. And then we should have plenty of time for questions. It depends. We have a lot of speakers packed in to this 3.5 hours. We may sometimes have time for questions, sometimes we may not. But please submit as many questions as you want. And it's my job to kind of manage giving those to the people. I'll be moderating throughout most of the day. So 7:15, the talk will be a kind of an engineering talk about the modularization of the ventilator problem and the history of the ventilator problem as Tim and I understand it. Then at 7:45, we have Professor Michelle Melentine and Dr. Eric Schultz, who will be talking about the clinical issues and the treatment of the disease and the disease function, which should be a very valuable talk. At 8:15, we have several 5-minute lightning talks from philanthropists and foundations which have funded initial work on open source ventilators, including the Mozilla Open Source Support Foundation and Protocol Labs, as well as the US government, NIST, and the US Army Materiel Command. At 8:45, we're going to have a talk by two entrepreneurs who can talk about kind of angel funding and venture capitalism, for-profit approaches to this. Dr. Sarah Benson-Conforti and Narayan Sundararajan, who, by the way, has written a book about working in the third world on this. At 9:10, we're going to squeeze in a very important speaker, Michelle Lott, who's going to talk about FDA authorization. She has some other things to do today. And then one of the most interesting talks will occur at 9:15, where we talk specifically about the situation in the developing world. So we'll be hearing from Marcos Mendez from Brazil and Sao Paulo, Karina Malul from Kenya, and Rebecca Alcott from EWB USA, which has done a lot of work in Guatemala. And then finally, we will close the show with two talks that I think will be talking more about how we can do things long-term in the future. Karen Sandler, who's the executive director of the Free Software Conservancy, will be talking at 9:45. And then Dale Doherty, who has written extensively about what he calls Plan C, which is the civic and maker community response to the pandemic, will be talking. And then Deepti and I will finish up with some action items and closing thoughts. So I actually got through that a little faster than I thought. Maybe this would be a good time to take questions. I wonder if any questions have been submitted. I don't see any questions yet. So please feel free to ask any questions if you would like. And also, I hope you'll be making extensive use of the Slack channels. I'm going to pause just a minute and go check the Slack channels and see if there are anything interesting going on there. I don't want to get ahead of ourselves. Okay. So it's been suggested that I go ahead and accelerate the schedule just a little bit because later on we'll have more speakers. Tim, do you mind going ahead here? So I should perhaps introduce Tim. Tim is the ventilator lead for Helpful Engineering, and he'll talk more about what Helpful Engineering is. But he's one of the co-hosts of this sponsor of this conference.
I was muted there for a second. Got it now.
Okay, we can hear you.
Cool. Yeah, so I can get going on my presentation, kind of introduce Helpful as well as kind of how we see the space going forward. So yeah, I'm Tim Arts from Helpful Engineering. I've been heading up our ventilator space. We're a big organization than just ventilators, and I can get into that if we go to the next slide. So Helpful Engineering was founded just a few months ago, and it kind of based on the theory of effective altruism, of doing the most good that we can. I think we're out of presentation mode on the there. All right, yeah, so we currently have about 3,400 registered volunteers who are working with us. That's just the volunteers we have in our kind of expanded database. We have 16,000 plus signed up for our Slack. We don't have 16,000 very active users in our Slack. I don't want to pretend that, but we do have thousands working currently. And it started in response to the COVID crisis, and it started as a place where engineers would just kind of come together, connect with each other, try to build projects, and people would join and say, "Well, I got an idea for this," and get together and start working on it and start building solutions for in response to the crisis. And now we've really developed into an incubator for these COVID-19 related projects with a lot of infrastructure in place to help people who want to help and have skills to connect and get their projects, make their projects a reality through a lot of the resources we gathered together and put into practice. So I have our vision statement there. I'm not necessarily going to read it, but that's kind of our North Star at the moment. For what we're trying to do and where we're trying to go. If you can go to the next slide. So the way that Helpful is kind of organized is that we have basically three main layers. One is where we really started, where anyone can join and start a project. A lot of you are on the Slack right now, and you can you could start a project on there right now if you wanted to, and say, I have this idea. We'll start you a Slack channel, get together, find people, and you can use our network of people just thousands of engineers who are on Helpful's Slack to start developing a project. And once your project has developed a little bit and you have an idea, you're starting to go forward with design, we have a rolling proposal and acceptance process where you can submit a proposal and then become an officially supported project. And what that means is that you unlock these additional resources, such as our manufacturing connections, legal assistance, publicity, funding, to start moving your idea and your project to more of a reality. And not that a lot of those things aren't kind of ancillarily available to swarm projects, and not that there aren't swarm projects that are very far along and close to or currently being produced. But this is just kind of the way things go. And then once your project's ready to launch, we help you in spinning off your organization into your own organization. Helpful is not interested in being like an IP holder. We're all open source. We're not interested in grabbing your idea and making it our own. We want you to be your own organization, but we want to make sure you have the resources to get there. That's just kind of how we're organized. We can go to the next slide. So I think the best example of how we do this and why I'm talking about all of this is I think of our PPE projects. Our PPE projects, personal protective equipment, have already moved forward, and we've already spun off what we call the MASS project, which is making face shields and really close to releasing their safe reusable respirators. This MASS project started off as a swarm project, got official, we launched it, and we've already delivered hundreds of thousands of face shields to different community centers, healthcare centers, and such. And we've worked with Coca-Cola. Coca-Cola is providing the plastic, and it's a flat pack, super lightweight, super easy to make face shield that we've produced and distributed. And it's just a good example of an idea that someone had, and now it's in production based on our organization. Additionally, in the UK, we have 15,000 face shields already delivered to hospitals, care homes, clinics. And then we have more PPE projects ongoing, more respirators. The material for N95 masks is really in low supply, and so we're developing our own there as well. And we've had a lot of success in cloth masks. That was just about spun out into its own organization. And so with PPE, we learned a lot of things, and that's kind of our pathway and how this relates to open source ventilation is that ventilators are much more complicated mechanically, electrically, or electronically, and I think most importantly, regulatorily. It's getting a supply chain in place and moving forward with a ventilator, an open source ventilator into the actual market is a really big undertaking. And so we thought that we would start with PPE because it's a little simpler in terms of regulation and technology. And so the PPE is in and of itself could be the highest need we have right now anyways, so it's obviously a good way to go. But we also saw it as a test bed for more complicated projects because we weren't interested in just doing PPE. We have so many people were interested in doing a lot of things. So we move to the next slide. We can move to our ventilators. And so we have a wide variety of ventilators that we're working on, and we're using the lessons we learned in PPE to get those to market. Let me just pause my notification. Yeah, to get those to market. And so we have 3 officially supported, so kind of in that second tranche of projects, ventilator projects, offset ventilator, which is an ambu bag BBM pressing one, A.R.M.E.E ventilator, which has no moving parts, is all Venturi based, and then Respiratory, which is pneumatic. We have 3 other active swarm ventilator projects, and then 3 ventilator module projects, which I think we're going to get into a lot today, is looking at the modularization of ventilators, and that's something that is important to us. And those are flow volume sensors, as well as a manometer, which was spun off of a different ventilator project as we saw a need for it. And so I'm not going to get into the specific ventilator projects because that's not really the focus of the conference is any one technology, but we are working on a wide range of ventilator projects, and we are open to more. And we, if we can go to the next slide. We as a group and as a ventilator group really view safety and testing as the #1 priority, and so having this wide range of projects and some that might overlap with existing projects out there, such as our ambibag presser, might say, oh, there's 1,000 of those, why are you guys working on it? And I think that safety and testing is really the answer to that question. We have looked at a lot of products out there, and we don't believe that all of them are safe, and that's a big problem. And so we are choosing to find the most stringent regulations that we can and trying to follow them. And so all our projects are going to be looking to the FDA standards and greater for approval, or for our own internal approval. We think that patient safety has to be #1. There is a way to do this safely. There is a great need, but that doesn't mean that we can cut corners, and especially doesn't mean we can cut corners if we're working in a space that we're not used to. The nature of this panic and fastness is such that we have to keep testing as our #1. And if there's anything we could take from the presentation, it's that I think that testing and meeting ISO and other safety regulations is #1. Additionally, we're looking at the open sourcing and open licensing. Open sourcing is at the core of what we do, and in looking at FDA approval, there's currently only one FDA approved open source ventilator, and we'd like to see more, and we'd like to see that open source ventilator to be more open source. They have a paper out, it's the MBM ventilator, and they have a paper out, but we don't believe it's full design documents, and we are looking for that from them. Some other thoughts. Oh, sorry, I got a little lost there for a second. What we are seeing with the FDA is that there's a lot of open licensing happening where people are giving away their licenses for free to license their product. And a big reason for that with the FDA is that when you get approved with the FDA, you don't get approved for a design. You get approved for a design paired with manufacturing, and that's an important part of thinking about this whole open source space that is maybe a little foreign to us makers who kind of want to do it and get it done, build it, have it out there. And at the manufacturing side of it is where a lot of the safety checks lie, and so that's why I think we're seeing a lot of more open licensing rather than open sourcing in the kind of more approved space, and I think it's important to really center manufacturing and be thinking about manufacturing from the beginning, and that's something that we're running into in looking at our approval and our applications is having a manufacturer in place even when you are trying to be approved. So think about manufacturing and make sure you have a plan for that, and that and then when you look at our landscape, you can see that we do believe in a variety of ventilators. We have a bunch of different types, and we believe as COVID has as treatment for COVID has changed throughout the time of the crisis, we have seen the treatment plans change a little bit over time, and so we believe that having a variety of technologies out there to address different treatment types and different needs is important. But we also obviously see benefits to consolidation, which is where I think a lot of what the other panelists who are talking about modularization, where that comes in, that that if everyone is working on the same thing, we're wasting a lot of effort. And so having some consolidation into different parts of the ventilator, I think I think we would agree is a great idea. We're always open to a better way of doing things. We have changed designs, taken designs, and are really open to if anyone here wants to join and think that we could do things better, come on in and we will listen to you. So with that, I think I can answer a few questions if there's a little time. I see that there's some questions around. Someone asked, how are the swarm ventilator projects different from other ventilator projects? Swarm ventilator projects don't have as many resources, don't have many of the helpful engineering official resources given to them, because we just don't have enough resources to have every single person who makes a project come in receive, and that's the main difference. Emilio asked, does an organization similar to the FDA but in another country provide approvals that are not necessarily tied to manufacturing facility? If so, why not follow those standards and get those approvals instead of FDA's approval? That's a good question. There are other organizations that are providing approval. If you look at the UK, they have a totally different standard. Their emergency use standard is very different, and we believe that it's important that these standards, meeting the standards that are the most stringent, is important. It's kind of part of our philosophy in the ventilator space of helpful engineering, in that we don't see regulations as things to get around or overcome, and we see them as kind of a guiding light. To make sure that we're being safe. These regulations for manufacturing are there for a reason, and we are trying to meet those. But yeah, we could get approved somewhere if we wanted to, or start selling ventilators in a space that doesn't have as high approval standards. But it'd be so easy to miss something. We'd rather go for the kind of higher standards. What other, Rob, do you have any other questions? I saw a couple come in that I don't see anymore.
Yeah, there is one question that came in on Slack. Thank you very much. It is currently ventilator manufacturers are struggling with flow sensors. I heard there is a repository of flow sensor manufacturers as well as open source flow sensor solutions. It would be great if someone could point me in that direction.
Yeah, so I can answer for our organization in that our organization has, oh, I see that channel now. Our organization has 2 flow sensor specific projects, and then 3 of our projects have their own flow sensor components to their ventilators, which is also showing a need for consolidation. But we've talked very in depth about that and believe that all of our sensors that we're supporting all of them at this moment. We have enough people that it's worth moving forward with all of them. And so if you search the helpful Slack for flow sensor, you should be able to find them. So there's Project Flow Sensor, there's Project VISP. If you're in our Slack, you can search for. as well as in some of our, actually all three of our official projects have that aspect to it as well.
Okay, so let me interrupt you there, Tim. In the interest of
sure.
time, I'm afraid we have to go on.
Yep.
I just want to tell the attendees we are looking at the questions posted in Sharp VentCon 2020 questions. It's just there are too many questions for us to answer completely.
Yeah, and I'll jump in there and answer questions on the Slack as we go on.
Great, thank you.
Yep.
So I'm going to have to go on to my presentation now to stay on time. So a lot of what I'm going to say meshes very nicely with what Tim said. The title of my talk is Building an Open Ventilator Ecosystem. And this is work that was co-started with Jenny Filippetti. So I'd like to tell you a story. And the story is the story of the pandemic ventilator crisis as I see it. In the last 10 weeks, a lot has happened. This graph represents the need for pandemic ventilators on the vertical scale and time on the horizontal scale. On March 7th, there was complete chaos, and it appeared that even in the wealthiest nations, there were not going to be enough ventilators to keep people alive, which would increase the mortality of the disease. Around March 15th, everyone became aware of this, and helpful engineering, for example, started, and approximately 100 isolated teams started building ventilators. And thank you very much if you're one of those teams. On April 1st, something important happened. The Israeli Ambovent team released the first open source system that I think was documented well enough to be reproduced by an outside party. And so that was sort of a milestone. Throughout April, consortia like Helpful Engineering, and I think there are European consortia as well, brought together engineers and started to get better organized. And I'd like to thank those people for doing that. On May 1st, it was pretty apparent that the maker community had succeeded in doing what you might call DIY PPE, as Helpful Engineering discussed, that making masks and face shields was effective and that we had really made a difference. However, as Tim said, ventilators are much harder. Now, by May 1st, in what we might call the West or the wealthier nations, it appeared to be the case that ventilators were no longer going to be in high demand. And there are three reasons for this. This is not really a mistake on anybody's part. There were three important learnings that happened. Around March 15th, major manufacturers, including Ford, GM, maybe Tesla, maybe Dyson, started manufacturing ventilators under license, as well as the fact that the existing medical manufacturers ramped up production. So that increased the supply of ventilators. Around April 15th, doctors continued the process of learning how to treat the disease. And so invasive ventilators are still needed in some cases, but they're needed less often than we thought on March 7th they were going to be needed. So it's important that this technology be available to doctors, but it's needed in a lower percentage of time than we thought. At least that's the current thinking. Dr. Schultz and Professor Malentine may discuss that in the next session. And then third, the other thing that happened was on March 7th, it was clear that China, which has a very controlled authoritarian regime, was able to control the virus. It wasn't clear that the liberal democracies in the West were going to be able to do that. Now, by May 1st, it became clear from the experience in Italy and New York City that social distancing works, that although Italy and the United States and New York City have not eliminated the virus, they have at least flattened the curve, but they have done so by undertaking extreme measures which may not hold. As of right now, the US commitment to social distancing is starting to fade. We do not know what is going to happen. If we define a ventilator not to be a purely invasive ventilator, which can only be used when the patient is heavily sedated, but to include the detection of spontaneous breathing modes. so that it can be used non-invasively with a mask or a helmet, then it may be that the demand for that kind of ventilation is actually going up. Now, in some parts of the world, there may be a large number of machines that provide that kind of ventilation. In other parts of the world, unfortunately, there are not. As of this weekend on May 15th, it was very clear from the data that some parts of the world are experiencing exponential growth. Those are Mumbai, Tanzania, Brazil, and Russia. There may be other examples. As Tim said, personal protective equipment and sanitation will save more lives than invasive ventilation. However, this conference is about ventilation. We need to work on all of these things. It's also the case that if you do not have a good supply of therapeutic oxygen, you should probably work on that before you work on ventilation. It may be that approximately 5% of patients end up needing some kind of respiratory support that we might call non-invasive ventilation. It may be that around 1% of people who get the disease require invasive ventilation. Perhaps it's lower than that, but that's approximately it. In a way, this is good news because the maker community can address all of these problems. We can make non-invasive ventilators that are less likely to cause injury to the patient than invasive ventilators. Public Invention started early building this spreadsheet of all the open source ventilator projects. And we created a rubric for the evaluation of them based on openness, the ability to be built independently, community support, how much testing they have done. We try to keep this up to date. It's not easy. At the moment, there are over 100 somewhat open source ventilator projects on it. Now, redundancy is good. It is good that there are multiple projects trying to build open source ventilators. But if we were one team, if we were a planet-wide humanitarian engineering team, we wouldn't have 100 teams trying to do the same thing. We would modularize the problem. So Jenny and I came up with this basic modularization of a ventilator. The basic components are an air drive. That's what makes the air move. It could be a bag squeezer, a pump, a bellows, a fan, a pressure gating valve. The second module is a sensing module, which senses the pressure and flow in order to allow you alarming and monitoring to make sure that the ventilator is working correctly. In some designs, the sense module might feed data to the air drive to control it. That's not necessarily required, but it might be used in some cases. And then finally, you need a controller and a user interface. And the user interface is extremely important because overworked and undertrained staff can make a mistake with the user interface, can misunderstand something and harm the patient even if the ventilator operates perfectly. So the problem of training and having a consistent user interface is extremely important. So Public Invention has addressed the sensing module with a device we call the VentMon T0.1. And I'd like to thank Gloria Clark, who manufactured these for us. We have shipped 4 of these free of charge to teams that use them. We're calling it T0.1 because it's currently a tester. The act of being a sensing module makes testing and monitoring are almost the same thing, okay? Now, the key to reuse among teams is to have good standards. If we have standards for, in the case of sensing, respiration data, that is, we can control, we can have a way of talking about the pressure, the flow, the volume, the temperature, the oxygen content, the humidity, then we can share data between teams, and you'll see an example of this. Now, it's not for any one organization to set the standard, but we have created a draft standard. Of course, it's open source. You guys can make comments on it. It's in our GitHub repository. And it does something very important, which is to standardize the dimensional units used, so that if one team is talking about centimeters of water, another team is not talking about millimeters of mercury, for example. And I'd like to thank Jeff Mulligan for a lot of work on that. Now, we have produced a byte level standard so that we can use I²C, but we have a JSON binding as well. We have produced software, and I encourage you guys to go to these websites. They should be live right now. You can see the VentMon producing moving trace data if you go to these URLs. What you're seeing is the VentMon hooked up to the A.R.M.E.E device produced by the Million Vents team, which is part of Helpful Engineering or under Helpful Engineering umbrella. And it produces the user interface display you're seeing there, which is clinically what clinicians want to see when they have something hooked up to a patient. Now, this is in test mode. It's not hooked up to a patient. I believe the A.R.M.E.E team has it hooked up to a Michigan test lung right now. And it shows the things that you want: pressure, flow. The bottom trace actually shows humidity, temperature, and computes the volume of each inspiration and expiration. That allows you to compute the clinically important features and to alarm on them. This software is necessary for testing. I do not want to say the software is awesome, but it consumes a standard data stream. Therefore, if someone doesn't like the software that I wrote, they can write their own and consume the PIRDS data stream, and it will work just beside this. Likewise, you can produce this data stream, this user interface from our software without having a VentMon, so long as you conform to the standard. By creating such standards for both respiration data and control, we can do the engineering modularization of the problem. Okay, for example, it's very common to build a ventilator based on what's called a bag squeezer. So you take an ambu bag like this one and you squeeze it, and there are certain advantages to that. Some people have said that's not a good way to build a ventilator. If we had a proper control standard to control the air drive, you could start with the bag squeezer, and when the bag breaks or becomes stiff or wears out, you just replace it with a pump. The patient and the doctor don't care what produces the air, as long as it produces the air in a very, very carefully controlled manner. By doing this, we might allow different teams to work on different segments of the overall ventilator problem. And by the way, Rob Geisbert has written a very nice set of essays on his system called the pressurizer, which is not really a ventilator, it is an air drive. He has solved the problem in a way of doing the air drive, and I'm working with him to try to work with our standard. This is too big to really go over, but the point here is this is the way you modularize things. The red lines that you see on the screen need to transmit standardized data. If they do, we could have a hot swappable air drive, which would provide tremendous advantages. Okay, so the principles that I think demand openness and modularity. This problem requires openness and it requires modularity. As Tim said, this is 90% testing and 10% design. Ventilators are simple, but simple does not mean easy. They have to be very, very carefully controlled in what they do. Engineering modularity, as I've discussed here, provides supply chain resilience. Why? Because if you can't get one part in Kenya or Brazil or wherever you are, you can replace it with another part so long as it conforms to the standards. Softening or smartening of components so that they can interact with known electrical standards and known information standards allow versatility through replaceability of those parts. Mutability of design provides flexibility of treatment, which I think is incredibly important. We want to give the doctors all the possible changes that they may require as they learn more about this. Cooperating teams might let us move to faster deployment through reaching the critical path and saving the first life. And finally, as Tim said, openness is the key to having confidence through peer review and third-party testing. In this situation, you want your ventilator to be tested by someone other than the team that built it. Why? Not because the team that built it has some sort of malfeasance, but because they're proud of their work and they don't want anyone to call their baby ugly. So having a third party examine it is useful. Now, to those of you who have built what I might call smart invasive ventilators, or dumb bag squeezers might be another way of saying this. Your time has not been wasted, all right? What has happened as a community is we have evolved. We started out thinking non-smart invasive ventilators were enough. We have learned it's better to build smart, which means able to sense spontaneous breathing, non-invasive ventilation. I believe we don't know what is going to be needed in the future. It may be that our efforts are simply mothballed for the next epidemic. It may be that doctors learn a different kind of ventilator is needed for this effort. By building an open ecosystem, we can handle that uncertainty better than anything else. Okay, so I unfortunately can't see the questions while I'm in presentation mode, so I'm going to stop sharing now and try to answer a few questions. Let's see. Forgive me. Oh, there's a poll up. I suggest you guys answer that poll while I'm trying to figure this out. Okay, the common data format is on the public invention GitHub. It's well documented in a markdown file there. You can find the specification. It's also embodied in code in both JavaScript and C code. If you want to use, we're trying to improve the C binding for it. Who is speaking right now? I am Robert L. Reed. I am the founder of Public Invention. Okay, we're going to have to move on to the doctors very soon. I'm afraid I don't see any other questions. So thank you. I'm going to go back. Michelle, are you ready to present? Let's see, Michelle, you're muted right now.
I'm just having trouble getting my video on because it says the host stopped it. So.
Okay, Michelle, would you like to? Okay, there's a question for me, Michelle. Would you like me to present your slides, or would you like to share your screen and do that?
I'd be happy to share my screen.
Okay, could you please do that? That'll make it easier for me to moderate. I know we thought about doing that. Let me just answer one question. Go ahead and share your screen and we'll get started. So Jamie Waters asked, how much does the flow sensor that you showed cost? If you mean the VentMon, the bag of parts cost about $250. We are giving them away free. We have been given a grant to give them away free to teams that are doing design work. However, it's completely open source, so you can build your own. If you mean the VentMon. The flow sensor is a part. As Tim said, that part is now very hard to obtain worldwide. However, Helpful Engineering has open source repositories for building your own. Here's an example of one using a 3D printed Venturi tube, which is a different way of doing it. Okay, Michelle, let me go ahead and let you begin. Thank you very much for your questions. We may be able to answer some of these questions in the Slack after we're speaking, so please just keep the questions coming and we'll get them all answered. Now, let me introduce Michelle Malentine. I only met her a few days ago, but she's done some excellent work. I believe her postdoc work is all around ARDS and ventilator-induced lung injury. She is a professor at Colorado Mesa University, and she's a specialist in this. I wish we could give her more time. She's going to talk, and then Dr. Eric Schultz is going to take over. So thank you.
All right, thanks for that introduction. I'll go ahead and get started. Before I begin, I just want to go ahead and thank my collaborators when I was a postdoc, because I'll be talking about a bunch of research that they assisted and helped me with, and things that I was working on. All right, so the goal of my presentation is really to define the problem from my perspective, which is how do you ventilate someone safely with acute respiratory distress syndrome, or ARDS? And so safely, I think, is the key word here in the thing that I really kind of want to get you guys thinking about throughout this short little talk. And I want to start from a place that is really looking at lung anatomy, so we're really all on the same page. And so one of the ways I like to think about the lung is through a tree analogy. So if you think about the trachea as the trunk of the tree, and then as your tree begins to branch out, as your branches get smaller and smaller, you would have leaves on the ends, but instead of leaves, we have alveoli, which are air sacs. In COVID-19, the virus actually targets a cell within the alveoli, which is a type 2 cell. And these are the cells that actually make surfactant in the lung. And surfactant plays a very important role in terms of reducing surface tension forces so that when you breathe, your lung can readily open. So when we're talking about acute respiratory distress syndrome, or ARDS, this is characterized by the point in which you have sufficient fluid or edema in your lungs such that you can no longer breathe to keep yourself alive. And you must breathe, you must have basically a machine that is going to replace normal breathing for you. So once you would get to that point and you would need to be mechanically ventilated, you would have ARDS. In a pre-COVID era, ARDS was actually something that was a concern and something that we were working to solve. In the United States, with the best care available to you, if you're being mechanically ventilated with ARDS, you had a 40% mortality rating. So your odds of making it were only 60%. In a COVID-19 era, this has dropped to 50%. So it means your chances of making it are 50-50. Pre-COVID-19, this caused 75,000 annual deaths in the United States. And of course, this number is much, much higher. Many researchers that study ARDS, as I did and still do, feel that to improve care, we need a couple of things. And one of these is models that can help us identify what safe ventilation is for each individual. And this would allow us to develop more customized care in the clinic. So really, ARDS is hard to treat. And what I want to do is help kind of give you some ideas about why it's hard to treat so that you can kind of keep this in mind as you would be working on different projects. So if you're someone who's a little bit queasy, I would encourage you to look away for a few seconds. But so here's an example of what a healthy lung looks like. So this is a lung that hasn't been ventilated, it's been inflated and tied off. And this is actually a pig lung. So if you look at this lung, you see this nice healthy tissue, this kind of foamy substance here, we have surfactant. And then if you have a lung that has been ventilated. So the lung in A and then the cross section of it in C has actually been ventilated in a pretty safe way. The lung in B and D, however, has not. And you don't necessarily need to be a clinician to look at the lung in B and D and be like, I really wouldn't want my lung to look like that. And one of the differences between how these two lungs were ventilated is the degree of strain of the tissue. So if you have something that had low dynamic strain, so the lung was prevented from repetitively collapsing and then overstretching, you're going to have something where you have a little bit of injury, some kind of this sparse kind of splotchy coloring would indicate some damage. But really, when you look at the high dynamic strain lung, you see sections of the lung that were truly blown out. And really, the darker the red, the more blood and other things that had gotten into the lung in that particular region. So if you actually take a cross section of the lung tissues, this is a cross section of actually a mouse's lung. And when I look at this lung as someone who studied this from a modeling and engineering perspective, what I see is something that is highly mechanically interdependent. So all of these little kind of bubbles that you would see in here, this are actually the walls of the alveoli. And the alveoli in the lung, they're highly mechanically interdependent. So they're sharing walls with one another. And they're actually, as you see, kind of these larger cross sections here are going to be more airways. But when I think about this from a mechanics point of view, and if we zoom in more to these alveoli, you can see they're all sharing walls. We have a healthy lung, and then we have an ARDS lung that's been injuriously ventilated. And in this particular micrograph, the sort of blue regions that you see here would indicate edema or some amount of fluid in these different little air sacs, which is where gas exchange can occur. So this is a SEM image, or a scanning electron microscope image, which looks at the surface inside some of these alveoli. And I like showing this image when I talk about sort of the two main mechanisms of ventilator-induced lung injury. So when a machine is breathing for you, we can have a couple of different things happen. We can have what's called atelectrauma, which is when you would cyclically reopen and collapse one of the alveoli in the lung. And you can have what's called volutrauma, which is when you overinflate and overdistend or overstretch some sort of region in the lung. And in the field that studies the respiratory structure function of people that have ARDS, it's really a combination of these two things that can lead to the most injurious kinds of ventilation. So when you look at this healthy lung, you can actually see a junction right here between two different kinds of cells. And when you look at the surface of an unhealthy lung, you see a lot of different things. You see macrophages, you can see a red blood cell here, you can see that it's been teared. And if you think about what happens in this idea of something cyclically opening and collapsing, it's if you ever taken a piece of sticky tape and you put it between your fingers, and you find that when you put it in between your fingers, it kind of sticks together. And then eventually there's some point where you would rip it off of one side of your fingers and it goes on to the other. That can actually happen within an alveolus. And the cell, if you deplete the surfactant sufficiently by introducing more particulates in there that would disrupt surfactant function, this can actually lead one cell membrane to stick to another and actually rip the surface of one cell off into another. So really, my perspective is that everything within the lung is mechanically interdependent. And another thing that makes ARDS harder to treat is that the injury is unevenly distributed. So if we can understand how ARDS spreads in the lung, then maybe we can treat it better. So because the lung is mechanically interdependent, the microscale forces can influence regional stability. So this is a one-dimensional finite element network that I developed as a postdoc. And you can see where we have these darker blue regions indicate more flooding, lighter blue is less flooding, and then no blue is no flooding. So this would be a network of alveoli. And the darker the red would indicate higher strain. So you could see if one alveolus is collapsed, because of the surface tension forces being great due to the presence of edema, then what we have is higher strain in all of the neighboring alveoli. One thing that I would note is, while there are a lot of patient-specific models, I don't know if I think these models are really ready for prime time, and I would be willing to debate that with some of you on Slack. Heterogeneous strain is really the most injurious kind of strain that you can have in the lung, and I think you could see that from the pig images. But unfortunately, it's really hard to avoid some high amount of strain, because high strain and high pressure are needed to open up the most injured areas of the lung. So what is safe ventilation in one region of the lung can be unsafe ventilation in a neighboring region of the lung. So in summary, what this means is if you have COVID-19 and this develops into viral pneumonia, this can progress to ARDS, and you would be on a ventilator from days to weeks. So identifying what safe ventilation is becomes even more challenging due to the fact that the mechanical properties of your lung would be changing fairly rapidly. So care is difficult. And with that, feel free to email me if you have more questions, and I will be answering questions on Slack.
Okay, so we need to go very quickly here. There was you're getting thanked by Teresa Barnes for your work on this. Thank you very much. We're going to have to go on to Dr. Schultz. I saw a very complicated question go by about CPAP and pulse oximetry. I think we're going to have to wait to save that. So why don't you go ahead, Eric? Eric, are you ready? You may have to unmute yourself. I'll unmute you, Eric. DP, can you unmute Dr. Schultz?
Yes, Robert.
Okay.
Hello.
Great, Eric, we can hear you now.
Great, and if I can start my video, that would be great too. I'm hoping I can share my screen, Robert. that will work.
You should be able to share your screen. It looks like Deepti has your slides there if you would prefer.
Okay, I would just, if I could go through them, that might be easiest if
Go ahead,
I
Eric.
may.
Yes, of course. Go for
Okay,
it.
thank you. Thank you. And I'm apologizing if there's any confusion because I'm sharing.
While Eric is setting it up, let me introduce him just a little bit. Let me know when you're ready, Eric. So Eric is an anesthetist, which in America would be called an anesthesiologist in Brisbane, I believe, Australia. And the great thing that he's done is he's written a 4-volume introduction to engineers around this basic problem. Okay, are you ready to go, Eric?
I am. So thanks very much, Robert. So yeah, so this is me. This is me about 10 years ago. Actually, I don't look that young anymore, and that's the hospital that I work in. So thanks, Robert, very much for organising this conference and to Public Invention. And I'd like to acknowledge that I'm sitting here in Australia, and in Australia, the white people just arrived and stole the country off the Aboriginal people and never really recognised that or had a treaty. So that many of us in this country like to acknowledge that whenever we meet. So there's a lot to talk about, and I appreciate time's quite tight. So in my slides, I've linked up to 2 documents. I'm going to try not to repeat the detail that's in those. The first link here is the document that Robert's alluded to, which is my 4-volume tome on what engineers need to know about ventilators from a doctor's perspective. And the second link is to a scrappier set of notes that I've just looked at as I've hit PubMed, and I've looked at the literature and looked at the recommendations coming out of the intensive care societies in the UK and Europe and the USA in the last week, and I've tried to really extract the absolute up to the minute thinking from those bodies so that we could use that as a foundation for what we decide and what we do from here. Yeah, so Robert asked me to address the question of what doctors need from us, and I think, primarily we need less patients. I mean, that is the critical thing. And there's a whole bunch of aspects to giving us less patients, washing our hands and staying away from each other and wearing face masks and all the things that public health people are telling us. I mean, that's so important. We need a lot more data. I'll get into this a little bit more, but we need randomized controlled trials of the various therapies that are available. It's extraordinarily difficult to translate a gut instinct into reliable into reliable facts that are actually the truth. Or what I should say is it's difficult to filter out what our gut instincts are and identify the ones that are actually true and which ones are just biased by our own experience and or biased by the fact that most patients live or most patients die, or there's other factors going on. So randomized controlled trials are really critical as we move forward. And quite possibly we may need more ventilators. Certainly, I mean, as Robert's pointed out, 6 weeks ago, everybody was saying, oh my God, we're going to run out of ventilators. We need tens and thousands of these things. Then it appears that it's got a bit more complicated. So I want to unpack that a little bit. It certainly may well be the case that countries like Brazil and others that Robert mentioned do need high quality ventilators. So, and that's really where my 4-volume tome comes in, is that high quality ventilator design and modularity that Robert has emphasised. How did I get involved? So I'm an anaesthetist. I put people to sleep and wake them up again, generally, or I do a lot of maternity work as well. So I stab a lot of pregnant ladies in the back with big needles and help them have their babies. And 6 weeks ago, or 4 weeks ago, I like everyone else was a little bit alarmed by what was going on, and was stuck at home for various reasons, and ended up watching YouTube and seeing all these videos of these very clever engineers making these machines that were going to be grossly inadequate. I could just tell by looking at them that I thought, oh, you're just off on the wrong foot here. Well, you need a bit of a briefing. So that's what I set out to do. And so I realized that most people were working on solutions that just were not going to come close to meeting the requirements of what we were imagining. But at the same time, I think I came to exactly the same realization that Robert came to, which was if people worked together a little bit more and broke the problem down into small components, and if people each took one individual chunk, that the problem's not impossible, it's not intractable. The problem's more complicated than a lot of people have realized, but it's not more complicated by an order of magnitude. It's maybe 2 or 3 times more complicated. So I still felt very hopeful that there is a solution and that we could deliver ventilators that were really excellent and would save lives, but we just needed to change the way that we went about it. So what's important in a surge ventilator? I think there's a couple of things that we can just dump immediately. One is the weight. I think we don't really need lightweight ventilators. These exist already. We've got self-inflating bags. If we need to get someone in a chopper and get them from one center to another, or in the back of an ambulance or whatever, we've got them to do that. We've got enough of these short-term ventilators, and they're designed to be used for a couple of hours or so. And maybe there's someone squeezing the bag manually, or maybe there's not. But this isn't really where the shortfall is going to be. So we don't really need portable ventilators. So if we're making something which is heavy and it's got a car battery in it or something, that's really not a problem at all. We'll put some wheels on it, and hospitals have got pretty good floors, and they're used to sort of very heavy patients and very heavy beds wheeling around on them. And we can put this ventilator in a trolley. I don't think there'd be many ICU ventilators that would come in under 50 kilograms. So weight's not really a big problem. We don't need to make this thing light. I think the other thing that people got misguided on is trying to come up with designs that were too cheap. We don't really need a $100 ventilator. Providing intensive care is extraordinarily expensive. It's about, it's at least $3,000 a day for an ICU bed. $1,000 a day at least for a regular hospital bed. So when we're making these ventilators, we need to bear that in mind. And even in the third world, you can argue that the cost will be a lot less than that. It's still going to be a significant cost. So if we're making a cheap ventilator that results in people staying a day longer in hospital than they need to be, that's going to be a false economy. So we can release ourselves of the requirement to make the cheapest possible ventilator. We're competing with commercial devices that are $10,000 or $20,000. So I think allowing yourself $1,000 budget, and possibly won't need to come close to this, but just give ourselves the freedom of spending a little bit of money on the hardware that we need to make something that's going to work. What is important? Failing safely is really important. I don't think reliability is great, but it's not critical. What I believe is really critical is if you do become unreliable, if your ventilator becomes unreliable, it needs to do so in a graceful way, which means that the people in the intensive care unit can step in and intervene immediately and take over, can just disconnect the patient from your machine, which is given up the ghost, and just use a self-inflating bag till another machine gets wheeled in. So I think that's the critical thing when it comes to reliability. Being available when it's needed. Now, this is really important, and this cuts across that issue with the component costs, in that the actual cost of a component may not be expensive, but the fact that there's a 6-month delay in getting that component shipped out from an overseas manufacturer, that may well be a major barrier. So while cost isn't a problem, we probably need to be making machines that we can procure the parts from very quickly. Robert alluded to accurate, reliable controls. I believe that any ventilator that's going to be worthwhile in this crisis is going to require excellent patient synchronization. And I talk about that a fair bit in the document, and more so in volume 3. And that requires a couple of things. Primarily, it requires really good sensors within the machine, and it requires a mechanism which is able to be quite dynamic and responsive to the patient's own respiratory effort. Robert alluded to the go ahead.
Let me interrupt. I just want to remind you, if you're going to take questions, you've only got about 5 minutes left, and
okay.
So at 15 after, we have to go to the next session.
Sure. Okay.
You are getting a few questions, which I'll present to you later.
Okay, great, thank you. So simple idiot-proof interface is going to be vital in that the ICUs are going to be staffed with people who are either going to be very overworked and very tired, or they're going to be very inexperienced. So that's important. So the caveats I went through, other than ventilators, ICUs need a whole bunch of things other than ventilators, so it's important that we recognise that. So human respiratory physiology is very complicated, and the really good news is you don't need to understand it. I think the alcoholic's prayer is really important here. You can control the things that you can control, which is pressure flows, temperature, humidities, and oxygen concentration. So if you as engineers worry about that, you can leave the physiology to us. But I just wanted to chuck some complicated graphs in here to confuse you all. And the main thing with these graphs is this is fundamental respiratory physiology, but the important point here is that they're non-linear. There's a bunch of non-linear stuff going on. So if things don't make sense to you, it's because of these non-linearities. And there's a bit more physiology for you. I've looked at absolutely the latest guidelines, and it appears that there've been some changes in thinking, and there's now 2 types of ARDS. We only used to think of 1 type, and now we've got H type and L type. And I won't have time to get into that, and it's probably not relevant. But we still do need ventilators. The evidence base guiding all of this is quite weak, and I think that's an important point to make, which speaks to my earlier point about needing randomised controlled trials. This is the latest evidence and the strength of evidence that the experts feel have got guiding their different recommendations. And this is all of these panels are just from documents published in the last several weeks in very reputable journals. This is the ICU data coming out of the UK, 15th of May, and I think this slide's really important. And for people who've heard these statistics about terrible mortality rates from ventilated patients, it's just important to remember that it's the sick patients that get ventilated, and they'll always do worse than patients who don't get ventilated. And this illustrates some of the patterns there and shows that in younger patients, the successful discharge rate is very high in younger patients, but the outcome in older patients is quite poor, and that's worth considering. The commonest problems I've experienced or seen in the ventilators that I've looked at is that they're grossly underpowered, and they've got poor user interfaces and inadequately instrumented in the dangerous failure modes. I just want to talk about the power briefly, and this isn't for the whole family here. The important thing about power is you can use a powerful ventilator gently, and it's easier to be gentle if you've got enough strength to be gentle. And I think that's a subtle but important point, which is why I think we should be aiming for ventilators that can deliver peak flow rates of 150 litres a minute as a peak output, and then we can finally regulate that. And this is just the modularity where I'd started to break down the ventilator, and this is just a cut and paste from my document that you can look at. And I just a comment on the hoods that are being popular. It's just worth noting for all your engineers out there that these are running on a fresh gas flow of around 75 litres per minute. And if these get deployed in large volume in the third world, they're going to need an awful lot of fresh oxygen. And I just want to mention that I think there's some scope to redesign these hoods in such a way that they don't require such a tremendous fresh gas flow. Just to put this in perspective, humans typically consume about 200 millilitres per minute. So if you're connecting someone to a device where you're requiring 75 litres, you're wasting a tremendous amount of oxygen. So whether we redesign these with some valves or things in them so they don't rebreathe, or using some soda lime to scrub the carbon dioxide out so that you can reduce the fresh gas flow, there's some opportunities to optimise this, and that would be critical if these things are going to be deployed in the third world. So I just wanted to highlight, it's coming up to 1 a.m. here, and I've got a case in the morning at 7 a.m. I'm going to be off delivering some babies. So I'm not going to be able to stay around for the rest of the session, but I will be around on the weekend, and I will visit Slack and answer questions, and I will look at comments on the documents as well. But I'm happy to I'll hang around for a little while, and I'm certainly happy to take comments now Robert. So that's
Okay.
all I have.
Thank you. And I apologize to the whole conference. All the speakers are going to be under time pressure because we packed a lot of speakers into 3.5 hours. So I don't want to be rude to Dr. Schultz or Professor Malentine, but let me ask a few questions. How important is capnography along with ventilators?
That is very important. It's possible we might be able to share capnography. There's typically capnography with every ventilator that exists in a hospital already. We really should be using capnography 100% of the time, but if we were only using capnography when the patient was induced or when they became unstable, that could be a workable solution.
Okay.
As well.
Okay, thank you. So Amy Kovelowitz, who I happen to know runs the Rice AmbuBag project, asked a question about making lighter, cheaper ventilators for the third world. Could you just state one sentence about that, Dr. Schultz, please?
Yeah, I think the third world will need good ventilators. I don't think a cheap ventilator that keeps patients in their intensive care units for days or weeks extra will be a good economy. I think we're better off making a robust ventilator with redundant monitoring and good user interfaces. So I think it's a false economy, I think, to make them too cheap.
Thank you. I'd like to point out that Sandy says Michelle gave a great presentation. I'd like to, I don't know, Michelle, you can think about this question. You're just going to have 30 seconds to answer it. Do doctors have to consider different types of ventilators based on the patient's level of lung injury? And I'm sure that's a complicated question. Let me direct this question to Eric, and then we'll finish up with Michelle answering that question when she gets off mute. Eric, Chris Young, who is a ventilator maker with Helpful Engineering, asked, how do you increase practitioners, and I think he means makers like himself and myself, digestion of knowledge? All of us are researching to try to understand this. You, of course, have written documents about it, but what advice do you have for us as, engineers who aren't MDs?
Yep. Keep it simple. Control the things that you can control. So this essentially comes down to delivered flow and pressure waves. Gas has got basic properties. It's got temperature, humidity, the composition of the gas, the fraction of oxygen, and then pressure and flow. And that's all you can control. And I read my documents because I've done my utmost to break it down into just the core bits and not drown you in a 6-month respiratory physiology course.
Okay. We have some other excellent questions, but we don't have time to answer them. I'm sorry. Michelle, were you able to unmute? Or Michelle, are you there? Ms. Malentine?
Okay, I think I'm here now. Really quickly, I think, the question of different types of ventilators based on injury is very true. I think there is definitely a role for non-invasive ventilation. And I think in severe cases of COVID-19, I think sort of a treatment could progress sort of in a way where you have, nasal cannula with oxygen, and then you would place a patient prone. In fact, 99% of physicians and experts in an ATS document guideline actually recommended prone positioning. And then from there, non-invasive ventilation has actually been shown to keep 20 to 30% of people off of invasive ventilators, where we know the odds are 50-50. So I think the more you can do to try to keep someone off of an invasive mechanical ventilator, the better. And so I think really there is a role for devices that don't require as many resources like drugs and other things to use them.
Okay, thank you. I'm sorry, there are some excellent questions here, but we don't have time to answer them, and I want to go on to the next session. So thank you very much. The next session involves two philanthropists, as well as someone from the U.S. Army and the NIST of the U.S. government. Jokai, I see, is ready here. Did Marta join us? DP, what is our plan here? Should I present or
I'm right
is
here.
Jokai gonna present?
I'm here. This is Marta.
Oh, great. Marta, are you ready to present?
Yes, of course.
Okay, great. Great. Could you go ahead and just share your screen and present? Or if you have
Absolutely.
slides.
Yes, no, I do not have slides. As I mentioned, I had a professor who used to say that power corrupts and PowerPoint corrupts absolutely. So I try to avoid slides when they're not needed. And in my particular case, they're not needed. I'm Marta Belcher. I'm very lucky to be outside general counsel to Protocol Labs. Protocol Labs is a company that researches, develops, and deploys improvements to internet technology, and open source is really at the heart of everything we do. So I'm really excited to be here today. As the company thought about our response to COVID-19, we knew that our direct contribution to response efforts was going to be pretty limited because fundamentally, we're not a biotech company. But we are firmly committed to supporting open innovation. And one of the things that we do to support the open source community is to give out open source grants to fund research in areas of interest to the company, like distributed systems and cryptography. So PL decided in March that it would give up to $200,000 in individual grants, up to $20,000 each through our COVID-19 Open Innovation Grants Program. We received 55 applications and we selected 10 projects, which were a combination of open source hardware and software projects. So for example, we funded some open source platforms for medical device design and for COVID-19 response, an open source ventilator related software project, and open source ventilator hardware projects. One of the most important criteria for us was that whatever progress or outcomes these grants were funding would be dedicated to the public domain or released under a permissive open source license. And in the few minutes I have, I wanted to talk a little bit about why we think it's so important that innovation in this space be open source. Of course, we're an open source company, so we think everything should be open source. But we think that open source can be particularly helpful for the specific challenge that you all are talking about here. As others have said, Robert in particular, from a practical perspective, open source offers the ability to turn a problem into modules and have teams and individuals across the globe work on the pieces that they are most equipped to handle or most interested in. And within each of those modules, it also allows different teams to try different approaches, solve the same problem simultaneously. So rather than one team trying different approaches one after the other, all approaches can happen simultaneously. And we think parallelizing a problem is really important in an area where time is of the essence. And it's not just about working faster. It's of course also about working better. As all of you know, open source allows you to harness collective intelligence and really turn a small team into a global powerhouse, which I think has been demonstrated already today with just the incredible folks, in this Zoom room, presenting and collaborating. It really allows you to tap into a well of cognitive surplus and utilize others' spare brain cycles. Fundamentally, open source software and hardware is peer reviewed. It's had more eyes on it and it's ultimately more reliable. And when you're talking about medical devices, of course, quality is key. We also think that this is a unique point in time where the traditional incentive structure that justifies proprietary thinking shouldn't apply. Backing up to the big picture, I'm an intellectual property attorney by training. The core purpose of intellectual property is to incentivize innovation. The idea is that R&D is expensive, so you grant people a temporary monopoly on their invention so that they can charge monopoly prices and recoup the cost of their investment. And the idea is that incentivizes them to make the investments in the first place. And it also incentivizes them to disclose their inventions to the world rather than keeping their breakthroughs a secret. And ironically, when people push that narrative, some of the classic examples of inventions that allegedly require IP protection are medical devices, specifically because it can require so much upfront investment. But there are other ways of incentivizing innovation, as it turns out. The way that canned food was invented is that Napoleon needed a way to improve food preservation so that he could march across Russia. So he offered a prize. And that's sort of what we wanted to do with our COVID-19 open innovation grants, is provide funds so that people don't need IP monopolies to innovate, and so that they can innovate in ways that are open source and allow them to tap into collective intelligence and solve these pressing problems fast and with peer review. And I think fundamentally, if there's any group that understands that incentives don't need to come from IP monopolies, it's this group. You're all here because this is a moment in time where we all have an intrinsic motivation to innovate in this space in order to save lives. So thank you all, and thank you so much for having me. This has been really a fantastic event.
Okay, thank you very much, Marta. I'm afraid we don't have a lot of time. Jokai, are you ready to go?
Let's do it.
Okay, so let me introduce Jokai Ben Avi. Maybe I'm not pronouncing that correctly, from the Mozilla Open Source Support Foundation. Take it away.
Thanks so much for having me, and for all the work that all of you are doing to help caregivers and the world during this pandemic. So you may be wondering, what's a guy from my favorite browser company doing talking at a Ventilator conference? I think Mozilla has long believed in the power of open source technology to better the internet and the world. And by its nature, as Marta was just talking about, open source technology development enables good ideas to be remixed and reused rapidly, allowing those good ideas to scale and be deployed where they're needed most. And it's been inspiring to see so many open source developers step up and collaborate on solutions to increase the capacity of healthcare systems around the world to cope with this crisis. And I think, like many companies and philanthropies, we asked ourselves, how can we best help to respond to the pandemic? There's obviously tremendous need right now. And it's always hard to focus on anything else when people are literally dying. But I think you also have to find a connection with what you have the infrastructure to support, and the communities you seek to serve. Since 2015, we've been running the Mozilla Open Source Support Program, which I'm privileged to lead, which broadens access, increases security, and empowers users by providing catalytic support to open source technologists. And as an open source project ourselves, Mozilla wants to give back to the community that we come from. But we also want to support projects out in the world that are advancing Mozilla's mission. And to be totally honest, at first we were like, well, is this really in our wheelhouse? And I think it was really seeing the many open source ventilator projects popping up around the world as the pandemic started to make headlines, that made us think that there actually may be a role for us here. And while we're not medical experts, we do know a lot about open source development. And because we're a project of the Mozilla Corporation, rather than a sort of traditional 501c3 foundation, we're actually already set up to give money to different types of actors, whether you're a traditional NGO or a for-profit company or a globally distributed group of developers connecting just over GitHub and Zoom without any legal entity. So it felt very natural to extend our existing Mozilla Open Source Support Grants program, which has always looked for impact beyond the browser. And so we launched the, MOS COVID-19 Solutions Fund, handing out awards of up to $50,000 each to open source projects which are responding to the pandemic in some way. And so through this fund, we've been able to support folks like Rob and the VentMon team to build their open source ventilator testing suite, but also projects like Recidiviz, which provides a tool to help jail administrators and government officials to decrease prison populations, which is critical because it's effectively impossible to physically distance in most prison settings. And therefore, there's a very high rate of infection, or high risk, I should say. I want to sort of transition for a minute. Like, rapid response funding is almost always difficult. And so I thought I would focus the rest of my brief presentation on sort of some thoughts on our approach to the COVID-19 Solutions Fund, which might be helpful for the folks in the audience who are working in philanthropy, but also might be helpful for those of you who are working on projects looking for grant funding to get a sense of how folks like me who lead philanthropic programs tend to think about these things. And so here are sort of 5 thoughts, observations on our approach. One, at MOS in general, we try to, in our grant making, to make catalytic investments. That's sort of to say, we want to give you money that will help you to sort of up level your work, or that will prove sort of transformational in some way, really allow you to get to that next level. And in that spirit, one of our committee members said she wanted to invest in high leverage projects, where we're not just funding one project, but helping a much larger community. And so, I think VentMon is a great example of that, where this is a project that we can invest in, we can support, that is supporting the capacity of a number of other different projects, as well as caregivers in hospital settings to sort of test out a ventilator that they may not be as familiar with and have confidence in it. Two, I think there's a lot of need out there. So find the spot where the needs intersect with your expertise and mission. For us, that's supporting open source software development and hardware development, I should say too. I think if you normally make clothing, make masks, like that sort of fits. But it turns out like it's a lot more difficult to build a ventilator than a lot of people thought. And so, you want to find some kind of nexus with your expertise, your resources. I think 3 is don't be afraid to ask for help. We've had a great experience bringing in some outside medical experts to help us evaluate the application. We've received more than 160 applications from 30 countries, and we had some great medical experts helping us to sort of take a look at that. And I think there are a lot of experts out there who can't do the things that you can do, but are looking to do their part, and providing you with some advice can be their way of doing their part. 4, I think we were looking to support projects that are already connected to affected communities and or hospital systems. It's hard to have impact quickly during this moment if you're coming in with a sort of, if I build it, they will come kind of attitude. I think we were looking for folks who are on the front lines. So, well, I should say, you should be looking for folks who are on the front lines and build connections with them, figure out what they need. What can you do that's additive, that can be deployed quickly and helps the ecosystem as a whole to cope better? And I think that speaks to Rob's point about modularization earlier. 5, I think during one of the prep calls for this conference, I was asked, should a project pivot if the needs have changed, even if that's not what I was funded for? And my short answer is yes, but talk to your program officer first. A little bit longer answer is, I know it can feel scary to talk to a program officer, especially when things are not going according to plan. But generally, program officers are genuinely nice people who are invested in you having impact. And like many philanthropic programs, we've reached out to all of our awardees to let them know we're happy to be flexible on the deliverables in our agreements. If you're a philanthropic program, I highly recommend you do that if you haven't done so already. And if you're a grantee, I always recommend you proactively reach out to your program officer, explain the situation, help them to understand either how you're responding to the needs that are changing on the ground, and or what your team are going through, right? Like, this is also affecting us as people too. And finally, I just want to thank you all for all that you do. That's it.
Okay, thank you. One question you might answer in the Slack is, are the grants still open? And I'm going to try to get Dr. Griffer set up now. Dr. Griffer, are you with me? Are you on the call?
I am.
Okay, I'm going to begin sharing your slides now, and we will go through your presentation. And I'm afraid you, like everybody else, only have 5 minutes. So please carry on.
Okay, very good.
And maybe introduce yourself, please.
I will do that. Thanks so much for the invitation to contribute to this conversation. My background sort of pushed me into the nexus of this response to the pandemic, as well as follow on. I was for some 25 years researcher in the European Union in several different countries. I later became adjunct professor of medicine at Wayne State School of Medicine, the Center for Molecular Medicine and Genetics, which is the 3rd largest school in the US. And then went into the auto industry, where I was the chief scientist for Daimler Chrysler and Fiat Chrysler. And currently I'm the associate director of cyber physical systems at NIST. That phrase may be puzzling to some people. I would say it's equivalent to the Internet of Things, with a focus on the interaction between software and physical systems. So what I'm going to talk about today is very much related to what these last speakers, including Eric, mentioned earlier. The problems that in this response were the basis for what I'm going to show you. I was asked some 8 weeks ago to assist the automotive industry, both in Europe and the United States, in building ventilators. I'd like to dispel that rumor right away. And I'm going to share with you some of the conclusions that came with my working with their chief officers who were in charge of their response to the need for expanding the production of ventilators. Just one comment that relates to what Eric said. Most of those global chief manufacturing officers of those automotives that have ventilator production partners, they predict a glut of ventilators about July timeframe. But I would remind everyone that the other remarks others have made is critical. The quality level varies greatly. If you go to the next slide, what we came out of this, what I came out with the team at the National Institute of Standards and Technology, part of the U.S. Department of Commerce, is that this was about supply chain, the response or the lack thereof. There are 5 components to what I'm going to show you: adaptive redesign, guided integration, intelligent supply, demand anticipation, and trust network. So we have gathered together partners, which I'll explain to you who they are, including Amazon, Google X, Cisco, and a variety of people who are in that supply chain for ventilators, and created an architecture for a system that's being stood up as we speak. If you go to the next slide and jump to slide number 4, challenge, I think, is apparent to everyone. What might not be apparent is the fact that this surge in demand for some things, while a lack of demand for others, is something that's going to
Edward,
persist. Yes.
what is the title of the slide I should be on?
It's number 4, and it says challenge and approach.
Okay.
Got it?
Yes.
Okay. So I won't repeat the challenge, but I will remind everyone that it is about a recovery phase and may very well be a revolution in how we procure and supply. If you go to number 5, Robert, adaptive redesign. I won't read the text for you. You can read it. The diagram was an early pencil drawing from Ford Motor Company, proposing the use of a blower motor and blower from an F-150 truck, a seat air conditioning unit, as a substitute for a blower motor in a ventilator. This should bring up all sorts of red flags, and I'll return to that. But the point is that you do need to broaden the supply chain in order to find potentially compatible designs for various parts and be able to redesign. Slide number 6, Robert. Guided integration. I'll simply point out that the partners that I'll mention to you have literally tens of millions of 2 and 3D drawings available, freely available, to help in the design, and packaging is a part of that, hence the drawings. Slide number 7, Robert. Intelligent supply. So by that I mean only that, as someone pointed out earlier, if a sensor, an oxygen sensor, for example, widely used in a number of industries, cannot be delivered on time, if there are transport capabilities or capacity that's not used, that needs to be brought online. Slide number 8. Demand anticipation. All of these pieces brought together in a platform, which I'm going to show you the architecture of, is currently able to anticipate demand and regionalize that demand. Very important to a response that's effective. Slide number 9. Trust is one of the things that's lost in the course of expanding that supply base along any level or tier of supplier. The partner IBM in this case brings under its blockchain practice the ability to inject trust through its blockchain technologies. Skip slide number 10. I'll talk about how it's implemented and go to slide number 11. The action plan that was hatched at that time, once I had conferred with the leaders of the automotive partners to the ventilator industry, was to simply amplify individual efforts. So one-offs were being created by states, Connecticut, Nevada, and I'm sure countries in Europe and Asia, These one-offs were matching of potentially usable parts in the production of ventilators. This needs to be brought into a distributed platform. The central elements, timeliness, of course, sustainable economics, everyone needs to get paid, put it simply, and resilience, which, by the way, is not something that has over the last 20 to 30 years in supply chains been rewarded. Resilience requires a different kind of thinking. Slide number 12. There are many pieces to this puzzle, but I will jump over this parts list. Suffice it to say that there is a platform which is distributed, Amazon-like, if you would, and many others. You need interfaces, you need data that corresponds to the things that are required in order to deliver that final product to the healthcare provider. You need intelligent AI-enabled search because the decision to choose a supply chain configuration has to meet those original requirements and a variety of best-of-breed tools. Slide number 13.
Unfortunately, Edward, I have to ask you to conclude in 1 minute, please.
Okay, so I will conclude then with this drawing, which basically describes a very distributed approach to bringing supplier, shipper, manufacturer, distributor, and design capabilities into a single configuration quickly and intelligently, as well as payment systems. So if you'll skip, Robert, to slide number 15, you may have to tab multiple times. I'll simply review some of the partners involved. Google X, sort of advanced development on the Google side. IBM itself with the Rapid Supplier Connect. Deloitte supply platform, which injects logistics services. The Business Roundtable and the National Association of Manufacturers. Thomas, which is a parts supply and offer site which expanded for COVID response under this paradigm. Ripley in cooperation with academics in Chicago, Concept in Connecticut, and finally several elements of U.S. government agencies. Thank you.
Thank you. I'm terribly sorry to have to be rude to such esteemed guest, but we need to get on to Kristen from the A.R.M.E.E. Materiel Command. I'm afraid I probably can't do a good job introducing you. I know you're an Iraq veteran who was a medic, but other than that, I don't know anything about you, and I'm afraid you only have about 5 minutes. So could you please begin, Kristen? Thank you.
Absolutely. Didi, do you have my slides that you could share with the group?
Albert, did you want to share your screen or?
Deepti, are you going to share the slides?
Yes.
Okay. Could you do that, please?
All right, wonderful. All right, well, good morning or good day, depending on where you are in the world. Thank you all so much for the opportunity to talk to you all today. As Robert mentioned, my name is Kristen Jones-Maya, and I work at the U.S. Army Medical Material Development Activity, or USAMDA for short, because it's easier to say, as a product manager. USAMDA is a part of the Medical Research and Development Command that's on Fort Detrick and Frederick, Maryland. If you could go to the next slide, please. So before I get started, I wanted to state that I have no financial or intellectual equities to disclose, and the views expressed today are my own and not necessarily those of the U.S. Army, the DoD, or the U.S. government. I am also not a representative of the FDA, nor am I a clinician. However, I was a combat medic in the Army during the early years of Operation Iraqi Freedom, and I've recently participated in a variety of DoD response efforts related to ventilators. I currently work, as I mentioned before, at USAMDA as a product manager, and I develop future medical capabilities for the Army. Part of this work entails working within the FDA's regulatory framework in order to field solutions. So kind of taken all together, I hope this helps to provide some context for the perspective that I am sharing with you today. Next slide, please. So as I've participated on various efforts over these last several weeks, it has become apparent that there are similarities between this situation and the future fight that medically we are preparing for. First, we saw a surge in demand and corresponding supply shortfalls in key items needed to effectively manage the COVID caseload. One of the first was ventilators, but the same situation has played out on multiple fronts. We also saw field hospitals being set up in unlikely places like convention centers and even the open spaces of PARC, quickly converting these spaces to functioning hospital wards despite not really being designed for that intent. The same creativity, flexibility, and resiliency that have been paramount during these response efforts will also be needed to treat and manage casualties in the future from an Army perspective. Strategically speaking, that future fight will not look like the last 2 decades of conflict. And from a medical perspective, it certainly won't be business as usual and will require greater agility on our part. We won't have a reliable resupply of critical items, and patient movement is going to be significantly hampered. Casualties will have to be kept in aid station-like settings for longer periods of time, and field hospitals will have to be mobile in a way that they aren't now. The days of quickly evacuating casualties to a field hospital and then out of theater will be gone. So altogether, medical resources and facilities could quickly become overrun, a situation that is not that different than some of the circumstances around COVID-19. What we have learned from being forced to do things differently now helps us to prepare to treat our wounded in that future fight. Next slide, please. So of those lessons I mentioned, I've listed 4-ish important characteristics of any solution that we put forth in the military, and I felt it certainly could apply here to ventilators. Rugged devices are probably obviously important for the military, but it's a quality that certainly adds value during response efforts. As hotspots move and change and resources have to follow demand, an item that can easily stand up to being used, packed up and shipped over and over again is critical, which also kind of leads to the next one, which is reliability. Devices that don't need frequent calibration and don't break quickly or easily and can run and run and run can do wonders for mitigating resource shortages. The next 2 on the list are 2 of my favorite, in part because it's the primary yardstick by which I measure most potential solutions in my day-to-day work. First, I'd like to talk about simplicity. A solution that is simple implies a few things in my mind. 1, for the end user, is it straightforward and easy to use? In the Army, medics are a vast majority of the workforce. If you can put forth a solution that the majority of your workforce can use, that is clearly preferable over something that only a specialist can do. But simplicity can also be a design consideration. A simple design might not only be easier to use, but it might also be more reliable and potentially more rugged. Last, and I'd argue most importantly, is effectiveness and safety. All the ruggedization, reliability, and simplicity in the world won't get you far if the device doesn't provide the intended and needed clinical benefit, all without risking the patient and even provider safety. So while I argue for the importance of safety and effectiveness, these other key considerations need to be brought concurrently into the design process and properly balanced. And before I wrap up, I would be remiss if I didn't say something about the FDA clearance and approval. In the military, every solution that gets pushed out needs to have that regulatory clearance and approval. And so just as we can't ignore this critical piece in our military medical product development, we also can't ignore it when we're looking at innovative ways of responding to this pandemic. And I watched, this has been a really hard lesson for some folks who have tried to contribute in this space to work through. Last slide, please. And so I just want to say thank you, everyone, for the opportunity to speak today and share some of my thoughts. And I'm happy to answer any questions that anyone might have.
Thank you. I'm afraid we don't have any direct questions. This is almost certainly my fault for trying to pack 4 speakers into one session, making it impossible to do that. But thank you, all of you. We now need to go on to Dr. Sarah Benson-Conforti. When Deepti and I planned this conference, we knew it was going to be very tight, but we wanted to respect the time of the attendees by having very short talks. So I appreciate the speakers being willing to put up with that. So thank you very much. Deepti, are you going to present Sarah's slides?
I'm gonna share it. I'm gonna share my
Okay.
slide with your permission. Hello, everyone. Can you
Thank
see?
you. And Dr. Sarah, I should introduce you, but I'm afraid I just met you so recently, you're going to have to introduce yourself.
That's fine. First of all, I want to thank you, Robert, and everybody who is present today at this conference for allowing me to speak and you know, be part of this amazing panel. As to myself, I'm a longtime entrepreneur, medical doctor in my background, and also an investor based in Silicon Valley. I reside in Palo Alto. Originally, I'm from Israel. Founded my first company at age 19. Had 2 exits in my background. Founded an early seed stage fund 3 years ago that is called Gimel Entrepreneurs Fund, that is based in Silicon Valley. So that's a little bit about myself. And I'll be happy to dive in here with your permission and talk about the funding roadmap from design to deployment and production. And I chose this slide, this first slide, to, as it mentions, do something great, because I think that in the overall, everybody here, you know, has the let's say the incentive of doing something great, unless we wouldn't be here. So I want to share this second as a gratitude to everyone that is trying to improve and help the world in this current condition that we're in. So when we talk about a roadmap of funding, it's really, you know, sometimes a peculiar process, because it really depends on what is the perspective that we look at what we do from. That means what is our state of mind, and what is that we are doing that contributes to what we are creating. So if I'm an engineer, a lot of times I would be prone to just start building it and without really thinking down the road, you know, of how this thing is going to get funded, and et cetera, et cetera. And if I'm a business person, a lot of times I would think down the road, you know, that I would need to strategize it according to a certain plan and need. And why am I stating this? Because I see it a lot of times as part of my work as an investor, and with meeting with teams that are actually creating any sort of a product. So this is a high-level overview of funding roadmap, beginning from idea and team, market research. The third one is MVP and POC, which is minimally viable product and proof of concept, traction, and of course, what does it mean to be capital ready? So let's start with the basics. So we've got an idea. Now what? So a lot of times we think, as entrepreneurs, we really love our ideas. It's really one of the things that define an entrepreneur, a fierce entrepreneur, that I think I have the best thing out there. Nobody else has what I'm doing. And I probably own the entire market. I've heard it so many times. So I think that one of the key factors is understanding that when you're building a product, you're actually not selling a product. You're selling a solution to a problem. And as part of that, we need to understand how to define and articulate that problem. And as part of that process, to talk to the customer. One of the, if we're discussing ventilators, and we know who is the person that is going to use ventilators, you have to talk to them from day one, even before sketching and drawing and starting to build things, because you need to understand perfectly how do they will utilize the solution that you're creating. So talking to people and validating your idea and researching your market and understanding your market very well will serve you a great deal, especially in the beginning. So we defined in our fund the 3 T's, which is the team, trust, and timing. And as you know, it takes a lot of effort to build a business, and it takes a lot of effort to build a project and to scale it. So finding the right team, or let's say gathering or pulling the right people together, is one of the most crucial things, because investors do not invest in products and ideas, they invest in people. So this is one of the things that I need you to bear in mind, that when you pull a team, you need to have a well-balanced team. You need to be complementary, and you need to know what you do not know, because this could be very, very valuable. And that's why I created this slide of the must-haves. So a lot of times we see imbalance in teams. We see teams that are more heavy on engineering, and they lack the business side, or they don't know how to seek funding, or anything about as it relates to scaling a product or finding strategic partners or whatever. They understand their own niche and they know how to build stuff, and this is great. It's great as long as you can pull it off, because at some point your product must have some kind of a value proposition to the world, and if that value proposition does not translate to dollars in a sense, that's going to be a problem. But having said that, since we are discussing today in an open source ventilator project, and a lot of this work is done for nonprofit, as we know, I think that even in the nonprofit world, we need to understand where the dollars that we want to, or we need to get as part of this project in order to scale it to areas that are distressed, for instance, such as third world countries that cannot afford to pay the full price, for instance, for a ventilator as it is priced in our market. We need to understand who are the key players, who are the key players that will allow us to basically fund our process, fund our team, and also subsidize the products for those countries. And I can give you an example. As part of, in my background, I was an interim CEO for a little while in a company that spun out of UC San Diego, Biomed Simulation. It was a company that created a patient simulation device in order to train surgeons and cardiac bypass, surgeons and perfusionists for cardiac bypass surgeries. So we realized very early on that we have a great need in third world countries for our device, especially in those areas where they don't have the abundance of what we call resources. They don't have the personnel to train people accordingly. So we created a business model where we varied our pricing. That means we let the countries that can afford the device pay for those who cannot afford the device. And that was part of our strategy, and that served us very, very, very well, because we accomplished 2 things. One thing, we accomplished the fact that we made our numbers, and the second thing we accomplished was we helped the world. And that's the thing that I want you to remember, that the fact that you're doing something for nonprofit or that you're helping areas in distress does not mean that you cannot make a business out of it. You can make a business out of it as long as you create a win-win scenario for everyone. So as part of the business plan and having a clear vision and knowing your numbers, this is exactly what I mean. When we talk about storytelling, it's very important to tell a compelling story, especially when you know that there is a competition out there. And as you know, having a competition out there is not a bad word. It validates your market. It means that if there are 4 or 5 or 100 teams like you that are pursuing the same thing, then you have a market probably, because this is a validation that this solution is needed, unless as many people wouldn't be working on it. So take it as a good point. Another thing that I wanted to mention about this, and as we talk about having an open source, when Robin and I discussed in the beginning, he mentioned, you know, Sarah, when I started this, I realized there are over 100 teams that are doing the same thing, or they're working on the same project. And I was talking about the silos that we create today in the world of research, and the way that teams do not tend to collaborate, but rather, let's say, isolate themselves from one another. So if I can make some kind of a suggestion or a call to action today, is if we know that we have 100 teams that are working to solve the same problem, reach out to one another, talk to one another. You are much stronger together than separately. And this is the message that I want to convey today, because the world is not made of a lot of silos. The world has become flatter and flatter because of the technology that we're creating today. If I'm in Palo Alto and I can talk today and be heard by somebody sitting in Beijing or in Tel Aviv or in France, in Paris, that means that we have crunched this space into a very narrow, let's say, a narrower domain of let's say, maneuvering and doing things. And we need to use it for our benefit. And using it for our benefit is not wasting resources, but rather consolidating, creating coalitions among teams. And this will push research and all these solutions forward. And it will make the health and medicine much more accessible and advanced than it is today. Believe me, if we only change our culture and mindset in research. So building a good foundation and not skipping steps. I want to talk about that, and especially since Christine, the previous speaker, has mentioned how important it is to have certain types of what we call compliance licenses, or let's say making sure that everything is complied by the law as it relates to creating a ventilating device, of course, because this ventilator must be able to do whatever it's needed, and also make sure that it doesn't harm the patient in some way. So very early on, it's very good to square away all the legal stuff. And that means if you can have in your team or by your side, or being consulted by somebody that understands this field very, very well and can place all the agreements, all the IP agreements, NDAs, everything that you need in order to be calm and able to move on with funding, and also going through due diligence very calmly, I think this is one of the must-haves.
Dr. Conforti, Chris Young from the audience would like to thank you for highlighting the real struggles of a multifaceted approach to humanitarianism with pragmatic pricing decisions. And I'm afraid I have to ask you to finish up in just 2 minutes, please.
Yes, okay. So as it relates to prototype, a lot of you here I know that are in the phase of prototyping. This is just an outline of taking it to the next step. I will talk briefly about funding types. So we have 2 funding types, which are the non-dilutive and dilutive, and they're very straightforward, and I'm not gonna elude you and waste your time with this, but I really want to talk about the non-dilutive portion of the financing, and talking about philanthropic funds and grants, and also being able to plug into an ecosystem, especially as a nonprofit startup. So being able to find and identify those key actors that can help you move forward and align with your vision find those visionaries out there that actually can push your agenda and are aligned with the same agenda of what you're creating. You'll be surprised that in a lot of areas, you'll find that those people can actually be your check writers as well. There's a lot of donations done by doctors and executives in those worlds. In early stage funding, I know that most of you here are in the range of the less than 10 million. And I know that some of you here also have approached what we call the government funding, the federal government funding. It's very important to know that the federal government has over $161.5 billion to deploy as part of their R&D budget. Okay. And I'll be happy to share this further if anybody needs.
Thank you, Sarah. It may be that in the Slack channels you can answer a few more questions. I'm afraid I have to give the floor now to Narayan Sundararajan, who has written a book about doing this kind of humanitarian work in the developing world, but I'm afraid I can't quite fully introduce him. But please go ahead and introduce yourself, sir.
Thank you.
Absolutely. Thanks for the opportunity. Fantastic setup, Sarah, for some of the stuff that I'm going to be talking about. So quickly, my name is Narayan. Oops. Are you guys able to see my screen here?
Oh, we can see. Yes, we can.
Okay, great. Let me do this. So quickly, just to introduce myself, I wear a couple of hats. One is as a CTO for a joint venture between Grameen and Intel. Grameen Bank or Grameen Trust, probably some of you know, or many of you probably know, was founded by Muhammad Yunus, who was a Nobel Prize winner. And Grameen Intel Social Business really is a social business that actually develops technology solutions for the rural poor and the developing world. Second hat that I wear very recently is as a co-founder of a nonprofit called LifeMech that we just started as a response to the COVID crisis with one of our first focus area being developing open source ventilators, which is the topic for this discussion. So what I thought I'd do is essentially maybe take you through a couple of products or solutions, as Sarah pointed out, that were developed as part of Grameen Intel Social Business, and then end with what we are doing on the open source ventilator space as the last part of the talk. So as Sarah pointed out, I think it's really, really important to really kind of understand what problem are we really trying to solve. Once we have clarity, that's about 60% of the solution, I think, and that's been our experience. So one of the first problems we wanted to tackle was in the healthcare space. It's sobering statistic. Even now, about 800 to 1,000 women die each year, each day, sorry, in many parts of the world, right, combined, right? And there's statistics out there on children dying during the first month of life. And it turns out that many of these can be prevented by giving the right information at the right time. So that's one of the use cases or problem statements that we really wanted to solve, the right information at the right time. The second problem that we were looking into is many of these women and children were actually being exposed to very bad indoor air pollution due to the fact that they actually cook with wood charcoal, cow dung, you name it, very inefficient combustion, and that causes CO exposure. And the numbers are staggering there as well, approximately 4 million deaths annually there. So that's the real problem that we were going to go try to tackle. And the way we did it was devising a solution, which is this device that you're seeing here, which is which is called COIL. It's carbon monoxide exposure limiter. It's also a bird in South and South Asia that calls out and sings, right? So this is a spin-off of canaries, which warned miners of dangerous air. And what does this device do? It gives pregnancy and infant wellness audio tips twice a week, every week during the antenatal care period, right? That lasts for 10 months. And it also senses bad air around you. And the beauty of this is it provides local language audio alerts, audio and LED alerts, right? So that we kind of take care of the literacy problem if you're trying to do it over the mobile phone. And the other thing that we really had to focus in on is making sure that it's worn all the time. It's in person for the pregnant mother. And so we really designed this as a bracelet or a bangle that the women wear 24/7 in South and South Asia, many parts of Africa and Latin America, right? But this is not how beautiful we started. So to make a point here, this was the engineer's bangle that we actually started out with. And you can see from the look on the face of the woman wearing this saying, what the heck is this, right? I mean, why are you giving me this? It's fantastic technology, but I'm not going to wear this, right? So the reason I'm pointing this out is it's really critical, not only to understand the problem statement, but as I think Sarah pointed out, to be in touch with end users, to be really in touch with the environment. So our process was an initial prototype, which was this, and really go field trial this out in countries like India, Bangladesh, and Nepal, and then come back and really design bangles that women can actually wear, not just can wear, but really actually wanted to wear, where technology kind of slides to the backside and it becomes part of the process. So we had to go localize it for Bangladesh, which is an important thread that you'll hear. It's great to develop a solution sitting in the ivory towers of the valley or somewhere else, but it's really important to make sure that one, it's scalable and localizable. And in this case, it was ethnically relevant designs, making sure that it's waterproof, because women wear this, they take a bath, they wash clothes, they wash utensils. So we had to really make sure that it's waterproof. We had to make it dust-proof, many different types. So there's a ton of localization that goes on in making the product relevant or the solution relevant to the target segment that we are looking at.
আপনাকে অভিনন্দন, আপনি মা হয়েছেন।
So those are the messages that actually come out, played to the mother, and it speaks like a friend to the mother. So it really becomes a friend to the mother is the feedback that we have got. I'll give you one more example here in the space of agriculture. It turns out that 90% of the world's farmers don't actually test their soil and still apply fertilizers. To make an analogy here, it is like me taking medication without knowing what I'm suffering from. That's literally what happens for about 90% of the farmers. And it's a triple whammy there if farmers do it. One, if they're not applying the right kind and the optimal amount of fertilizers, their productivity goes down, their cost goes up, and there's an environmental runoff. So that's the problem that we were tackling with this solution called Krishi, where we are really decentralized soil testing services. We really brought an expert in a box that an entrepreneur can take field to field, plot to plot, farmer to farmer, and take their soil and test it for the right lack of nutrients and provide the recommendation, much like you get a blood test report at the end of your blood testing. And
okay. So thank you, Narayan. I'm afraid I have to ask you to just finish up in 30 seconds. Could you please?
Absolutely. So that's the perfect timing here. So the latest approach we are doing here is in a nonprofit called LifeMech, where we are the problem statement is super clear to this audience, so I don't have to go to it. We have come up with a couple of different designs, one collaborating with the University of Florida effort. There's a point made about really go collaborate. We do that with this. The adaptive ventilator system is a very close collaboration with the MIT design. The PanVent system is a collaboration with the University of Florida. And both of those are actually going through FDA UA. And all of this material is going to be open source, completely open to use. The BOM, the A.R.M.E.E. BOM, the assembly instructions, every one of it, so that it can be used, but also localized in the context of the environment this needs to be deployed.
Okay,
and we're
thank
also
you.
kind of very humble about if the need goes away, we're also looking at what the future might be holding in terms of non-availability of oxygen supplies, vaccine cold chain monitoring, and other needs.
Okay,
So-
thank you very much.
Yep.
Okay, so while Michelle is getting ready, Michelle Lott is going to talk about FDA authorization. I'd like to ask, are there any of the panelists who don't want their slides shared to the attendees? I know Kristen Maya Jones, we've already removed your slides. Okay, thank you. So I'm going to take that as permission from the people here. Michelle, thank you. Once again, I apologize to everybody I have to cut off. We have a lot of fascinating talks. I hate being rude to somebody, but we have to get through these. Thank you. Go ahead, Michelle.
Okay, so I'm Michelle Lott with Lean RAQA. So I'm going to cut right to the chase here. I know most of the open source people who are designing and developing products right now are from other industries. And so the first thing that you need to know about designing FDA regulated products is that it is absolutely mission critical to understand design control and risk management. First off, is everybody seeing my slides okay?
Yes, we are.
Okay, perfect. So the FDA has a whole formal process for how to design and document design controls. And the most important thing is that risk management is integrated the entire way. And this even means to a point during the emergency use authorization. If you look at the table of contents for the emergency use authorization, several of the elements, which I've highlighted here in red, are direct outputs of the design and development and risk management process. So you really can't cut these corners. And in the ventilator EUA, there are over 20 technical standards from a variety of families that are cross-cutting and touch almost every aspect of your product design. We're going to do a quick case study on electrical safety design requirements. If you, no matter what kind of medical device you're designing, if it has electrical properties to it, you have at minimum these sets of standards for basic electrical safety, electromagnetic capability, usability, and alarm settings. And so if we quickly look at a specific example in these technical examples, just for the medical device power supply, you have to get into what type of environment it's used in. That type of environment depicts if you have to have, or dictates if you have to have air clearances and voltage creep. Then it gets down into very specific deliverables of your device design with power cords, what type of personnel are going to be installing your device. And that's just one specific example. So what happens if marketing comes back and tells you, oh, our bad, we need to be able to also use this for home healthcare, not just industrial healthcare, and it needs to have a multi-function patient monitor. Well, in that case, we have to take our design, go back to the drawing board with the technical standards. Just adding those two features at minimum adds a safety standard for home healthcare environments. It adds a separate safety standard for multi-patient monitoring, and it adds a FDA guidance document requirements for home use. So if we go back to the drawing board with our design and we look at just the aspect of home healthcare, it completely changes what our voltage clearances have to be. Not only now do we have to think about operator protection from the healthcare space, but now we have to think about patient protection from the home healthcare. Those have very different voltage requirements, output, and acceptance criteria. So if you are not very familiar with the technical standards, you're going to design a product that at the end of the day isn't going to meet the technical standard requirement and is not going to be able to be cleared by the FDA under the emergency use or otherwise. So if we shift gears and look at what's needed on the market right now. So Dyson thought they were coming to the rescue of the UK early on. And in 10 days and with $25 million, they developed this fairly sophisticated ventilator. And these are people who know how to design products with electrical safety requirements. However, when they submitted this to the MHRA declared that they did not need any more ventilators because they felt like a patient on invasive ventilation was just as likely, if not more likely, to die as opposed to non-invasive respiratory technologies. So what does that mean for the open source community and what your successful products will be? And this is my personal opinion, but I feel like the successful products are going to be non-invasive. They're going to be respiratory assist in nature. They're going to be low infrastructure in terms of power source requirements, gas supply, medical know-how. They're going to take into account the doctors per capita in the countries you intend to distribute them in. And they're going to be low in supply chain requirements, both to manufacture the device and both in the healthcare environment. They are going to be compliant with basic design controls and risk management and compliant with applicable standards. So don't forget about the free stuff. BSI has standards available for free that are worth thousands of dollars. And don't forget about me. And that's my time.
Okay, thank you very much, Michelle. There aren't any questions. You know, I have to say that talk tends to make our job a little harder, but I don't think we should get discouraged. All of those problems are problems which can be addressed. They just require time and study and work to solve all of those problems. So it is daunting to meet all of those safety requirements, but that doesn't mean that we can't accomplish that. Thank you for all of our speakers who have kept us almost on time. We're 3 minutes behind schedule.
On what it means with the FDA.
We're now going to begin a very important talk session. I'd like to introduce Marcos Mendez from Sao Paulo, who runs a consortium and has built one of the more interesting ventilators, which is very supply chain resilient. Please take it away, Marcos.
Thank you, Robert. My name is Marcos Mendez. I am a system administrator. I take care of a database of tickets for fixing equipment on the government here in Brazil for hospital equipment. I take care for more than 700 and something healthcare units and 62 hospitals. And I know every piece of equipment in each one of those. The company is run by my family, and I helped them in the last years to build this system on an open source manner to help them be transparent and efficient on fixing hospital equipment and gear for the people. Since we began OpenVentilator.io project, the main problem from my point of view is not to build a ventilator. Anyone with $5,000 can build a ventilator. Actually, it's a very easy piece of equipment. And the problem is supply chain. The problem is to understand, like Edgar Morin, a French philosopher, says, with a complex analysis of the situation, right? We are in a global pandemic. And let me try to share my screen. Sorry, Chrome, okay. And this is the project philosophy that I've been run for the last time. So global problems must have global solutions. we don't care about solving global warming only in Brazil, because global warming is a problem that's worldwide. So we have to solve it as the entire country, entire planet, right? So the second stuff is to understand that ventilators have been done by the last 100 and something years in human history. And also in the Bible, we have someone saying that ventilated a baby using animal, I don't know the name in English, of some kind of animal. So for solving the problem in Brazil, we of course have ventilators in many places, but we have a problem that 9 on each 10 cities in Brazil don't have even an ICU. So the problem is not the ventilators. The problem is that many of the places and the healthcare facilities don't even have soap. They don't even have alcohol for the doctors. I have a cousin of mine that's working with the same mask for the last 2 weeks in an intensive care unit. So the reality we have here is much more hard than what people really think. This is the phrase that our Minister of Health said to the people, to use socks and other kind of stuff as masks because we don't have masks. Also, teams making coronavirus research have been arrested and beaten because people don't want to believe that this is a pandemic. And I can see it every day on the number of people dying and on the database, the increase of tickets on the critical mission equipment on hospitals. This is evidence that we are living very weird times. So the project, since the beginning, had to deal with everything that was going on in Brazil. Also the overpricing of ventilators that the government was buying. So we decided to make a project that was very wide available on, so material agnostic, a project that was made for from the people to the people. So anyone with tools and resources and a few parts could build it, any place, anywhere. And also our main standard was safety, because we know that safety and risk management on these kind of situations is complicated. And the problem is that people are trying to solve safety problems with electronics. And we've been doing safety ventilators for the last 100 years without electronics. Mechanical safety, so mechanical valves, mechanical PIP control. So I think before attempting to build a ventilator, or before attempting to solve a ventilation problem on hospitals, we have to see what people have done before. This is a map of the parts of Brazil that the ventilators are on the public, on the government hospitals. And you can see here me in Brazil, in Sao Paulo, here down here is the most blue part. So we have widely available ventilators, but in the countryside, in the Amazonia region, there are even a state up here that you can see it doesn't even have ventilators. And so for building something that is reliable, Robert, I don't know how much time I have left. If you can tell me, just give me a call. So to build something that's reliable, we have to take these designs from old times here and make them so they can be built with a material agnostic and part supply, that it doesn't like, if I cannot find a part here in Brazil, but someone can find it in India, it's possible to build it. So
you should finish up in 2 minutes, Marcos. Thank you.
Okay, thank you, Robert. The other thing is that all these machines are from the 70s. They are not from the 50s, and they are invasive ventilators. The problem of a ventilator being invasive is that on a very high risk of patient is the only way to guarantee that the patient is going to have a chance of survival. When we talk about non-invasive ventilators, CPAP machines have been proven to get clinical cases worse than invasive ventilators. The problem of invasive ventilators is also that we need peripherals like gasometries, oximeters, and blood measurement that is not widely available everywhere here. So the problems are not ventilators. The problem are supply chain of equipment, and also that we have to think about the problem outside of the box. So if we have measurement, if you have a way of measuring oxygen on the blood without punching with a needle the patient and giving him an anticoagulant medicine, it will be much better to have an invasive ventilation, and it will increase the chances of survival. So Robert, I think my time is...
Yeah, I'm sorry.
Yeah,
Thank
no
you very
problem.
much.
Thank you all, guys.
So once again, I'm afraid we packed a lot of information in here. Thank you very much for the picture from Brazil. I'd like to now briefly introduce Karina Malul, who's worked with the World Bank, who is from the Kenya, I may have the name wrong, the Kenya Emergency Innovation Network. Karina, are you ready to go ahead?
Yes, I am.
Okay, thank you.
Thank you, Rob, and really thank you to you and the team to organize this. This is really, really useful, and we all, I think, very grateful. I also want to say thank you for answering many of our questions and finding ways to help the network in Kenya. So I'm going to start with just maybe presenting briefly what we've been through with this incredible ride in Kenya. So can you all see it clearly or enough? Yeah. Well, why this started, I think it's all shared here. It's really something we all been through and we all know. And we realized very, very early in Kenya that there was less than 500 ventilators, and most of them being already in use. And very fast, there was like all these discussions and fight and panic that, yes, the government and business would do the right things, and the donations and the orders and everything was going to go well. And the first delivery of ventilators went kind of missing, and then another one went kind of blocked. So these things are common, and we know they're part of the very complex network of issues that define a little bit the background. So very early on, we knew that Kenya would face acute shortage of PPE and of respiratory assistance. And like, I think everyone on the planet wanted to do something, we rushed on ventilators. And we met very early this fascinating global community of people trying to race against the clock, find solutions, give solutions, share what they were doing, and that was an incredible energy. And I think it created a lot of opportunities, and a lot of people said, wow, in Kenya, if we had always done business like we're doing now, we would never be in the situation. The openness, being constructive, finding solutions, being fast, being transparent, this also came with this network. So there were a series of steps. A lot of groups were created, first on food, then on 3D printing and ventilators, and then we had to split. So I think, I mean, it emerged kind of naturally. My background has been with the World Bank and with countries at war. So, and when I moved to Kenya about 6 years ago, I left the World Bank and I started to work in business and in food sustainability, in social and impact business. And I branched into like a whole range of sectors. But by doing this, I was already being part of a community of actors that are really stepping in for key social and economic issues. So from the first day, there was all these groups coming up. And it took something like 2 weeks before being structured around work streams and specific groups. And we, as a network, we provided the medical technical advice. We started lining up manufacturers, engagement with hospitals, engagement with the government, and fundraising. And simultaneously, we started on ventilators and face shields. And gradually things came. Oxygen was on our priority since day one, but it just didn't happen. The connections were not there. These are very, very siloed and very different worlds. I mean, the gas companies, the manufacturers that are mostly in their 60s, the tech people, the engineers, the medical, these are so siloed that it was very, very hard to find the basic answers on what are the needs and what are you going to use, and even harder to get the answers. So now we kind of more or less set on these ones for the last 3 weeks, but it's likely to change. And as all of you know, we all react to the evolving knowledge. I won't speak too much about the ventilator teams, but we started with 12, and now there's 4 who are reaching a level of going through the tests and presenting to the various government entities. And I don't have a picture there because that's part of our issues, and the issues I think, I mean, a lot of us have faced. So our collaboration, there were some wins, and I think I mentioned them. We pulled resources, we were efficient at sourcing specific parts for prototyping. We somehow brought some more clarity to the process with government and institutions. We're able to involve youth, to have people working together they would have never met before, leapfrog effect, and thanks to a lot of other teams and network out there. But the obstacles, and I think they've been mentioned quite a lot now in this discussion, I mean, these egos, and it's when competition becomes kind of a bit blinding and people starting to close. And we had some of the teams just basically leaving the group because they were told by the chancellor, or they were told by whoever was the head of the committee that they're not allowed to share anymore. And yes, I mean, corruption is a big issue, and we discussed it quite a lot with our colleague from Brazil. So there are major issues that are structural to collaboration, but are also structural to I won't say third world country. I would say countries that are more challenging infrastructures and resources. They definitely do. So at the network level, we had several issues, and I think some were mentioned also in the questions. We are still struggling to find the right platform to combine nonprofit and sustainable and impact business. And it's not easy because you have people with different margins and people who are not willing to share, but they're still very useful. So this has been a kind of very difficult question we haven't been able to completely solve. There's been also some issues raised, I think, in the questions too, about the legal aspects of the product. And even if it goes through all the certifications, These are nascent structures or consortium, and we are entering a world we have no clue what it is going to be on the liability aspects. I think we've passed the dilemma now about, we've heard at the beginning so many doctors then telling us, no, never over my dead body, I will ever use a machine like that. And then at the opposite, there were the other ones, like between no air and any air, I will take your machine. I think we're now a bit beyond that because the knowledge about the disease is better. We still have this issue about responding to the short-term emergency, which is now a little bit diffusing because the numbers are not going so high and so rapidly, and the need to be sustainable because we know this is not going to go away in a couple of months. So these are now the kind of what I would say the specific issues around the situation in Kenya. So you have the issue of power, I think, like Marcus has said, and there was a team at the beginning looking at renewable energy as a source, and then it didn't work. But then looking at the batteries that need to last much longer than the usual ones. Oxygen has become a very important now work stream for us because there's a very, very tiny minority of hospitals that have oxygen. It's going to be oxygen cylinders. And it resonates also with the, I think one of the points that Eric said about the hood being very, wasting a lot of oxygen. So that has been, that is now a very, very important issue. It's linked to my last point, which is theft, because in Kenya, cylinders disappear. So one of the projects is now to have a cylinder tracking system. And that raised so many issues on safety because they are used for scrub or they are refilled by non-certified producers. So it is a massive issue. I think it was also raised by several presenters, the fact that this interface and the fact to make the life of the health workers easier is going to be essential, especially because the ratio health staff to patient is not going to be sufficient. And like it's been also raised, thinking about this thing and thinking about producing locally, it means that we need to reduce the amount of things we need to import. And that is a real challenge. I mean, sensors, there's no way. We've had a lot of issues with importing things into Kenya. Now it's becoming better. Just the 300 to 400% markup on importing things into these countries. It's been
Corinna, I'm sorry to interrupt, but I'm going to have to ask you to finish up in time to let Rebecca speak.
Yeah, and well, I mean, you've seen the other points. The last aspect, so in 30 seconds, I think from the beginning, we supported several work streams. We had to move from one to the other, and we continue to do that. So from our 12 teams, half of them have pivoted to other respiratory assistance device, and we try to support them this way.
Okay, thank you. I'm terribly sorry to be rude. This is fascinating. I'm learning so much. I do have one question from Philip Bowman, who I happen to know is a volunteer for Engineers Without Borders USA. For Kenya, he asked, can you quickly discuss pros and cons of improving an O2 cylinder distribution versus expanding availability of O2 concentrators?
Well, there's 1,000 concentrator. We have no idea of the maintenance. And so it would mean importing more. And we have one team working on oxygen concentrator, and they're not that well advanced, but we're supporting them.
Okay, thank you. I have another question. Are MAF airflow sensors available there in Kenya? And I believe what they mean by that is the flow sensors that you just plug into the airstream.
I mean, they're available if you import them.
Okay. The anonymous attendee clarifies the question by saying automotive airflow sensors that can be repurposed for this purpose.
their sensors from cars don't work because they are mostly reading between 20 and 20 something oxygen percent and not 100%. And also they are made for working on high temperatures.
Okay. Well, I'm afraid we're going to have to go to the spec sheets to answer that question, but thank you. Rebecca, are you ready? We're a little short on time. That's my fault. Thanks. I'm terribly sorry to be rude to people. Rebecca Alcock is a recent Masters of Science graduate who volunteers for Engineers Without Borders USA, which, by the way, I volunteer for, and she has some direct relevance. Thank you. Take it away, Rebecca.
Yeah, hi everyone. It is such an honor to be included in this conference. I'm going to fly through this to try to keep us on track here. I'm part of the COVID response team for the Engineers Without Borders crew. We started our work in Guatemala in about mid-March, and we were able to move really quickly. We focused on deployment rather than design of ventilators or PPE items. And our response has garnered attention from the UN Development Program, USAID, the UN Tech Bank. And so hopefully, I'm sure I'll reiterate points that have already been made, but I hope to leave you with some new ideas as well. So to just provide some context, this kind of all started and was successful because of partnerships that were established 2 years ago when the volcano Fuego erupted in Guatemala. I was actually living in Guatemala at that time. And those bottom two pictures on the left are from my personal photos, but it was really devastating. But EWB came in and was able to partner with the local Rotary clubs, basically the FEMA of Guatemala, so their disaster response organization, as well as the Ministry of Defense, to rebuild after the eruption. So the silver lining in all of that were these partnerships that we were able to establish about 2 years ago that led us to respond really quickly in Guatemala. So this is EWB USA's mission statement. Basically, all we're trying to do is meet the basic needs of our partner communities. So in terms of COVID response, we've really focused on deployment and technical assistance. Like I mentioned, we're not doing a ton of design work, but what that looks like is personal protective equipment, so enabling local production of those things. I'll talk on the next slide really briefly about why the local production piece is really important. Medical devices and ventilators, so we're working in countries where, in Guatemala, for example, there are about 200 ventilators in the whole country, and a large percentage of those are broken at this moment. And then also infrastructure, so helping hospitals set up isolation areas or fixing their water systems. Imagine fighting COVID without access to water, especially in a hospital setting. So those are the three areas we've really focused on. And to date in Guatemala, we've been able to distribute over 100,000 units of PPE to 12 plus partner hospitals and midwifery groups. We've also conducted a survey of the existing ventilators, and we're diagnosing how to repair those and what we can do to get some of them back up and running. And then also this infrastructure, like I mentioned, we've worked with 4 hospitals so far and have a list to continue. So there are probably 1,000 lessons I could provide about what we've learned over the past few months doing this response. So what I'm going to talk about is just these big picture, the context surrounding a COVID response in an area like Guatemala. So the big picture to us means counterintuitively being very detail oriented about the non-technical aspects of design. So we need to approach these solutions more holistically and talk to our friends in the social sciences and in business, and most importantly, those with actual boots on the ground, or as we like to say, homes on the ground. So who's actually living and working and experiencing that reality. So in terms of deployment, you could design a great product, but if it has nowhere to go and no way to get there, all you have is a great product. You don't have a useful product. So for ventilators specifically, like other colleagues have mentioned, that means, is there enough oxygen? Are there enough respiratory therapists that can run these machines? Do you need to provide training? Is there a secure supply chain for filters, for anesthetics to keep the patient put under for the duration of the time they're on the ventilator? If the power goes out in the middle of somebody being on the ventilator, what kind of safety measures do you have? So that's one area, is deployment. Another one, there's been a lot of fraud surrounding PPE. And we always say that these communities in these countries that we're working with don't have the money to make a mistake right now. We're providing technical assistance to make sure that there's some level of quality control, especially with importing certain PPE items. But you really need to understand the bigger context of the country. And then lastly, just the appropriateness of the material. And then if we need to find other secure supply chains for that country, that's kind of where that technical assistance or adapting existing designs comes in. We've relied heavily on the open source movement. So we really want to thank you all for being a part of that. And that's been crucial to enabling the local production of PPE in these places. So I know that I'm out of time, but I will be hanging out on the Slack channel, and I've got my email here on the next slide. Feel free to reach out to me with any other questions. Thank you.
Thank you ever so much. Ms. Sandler, are you ready to go?
I am. Can you hear me?
Yes. Yes, we can hear you just fine. Please go ahead. I can't remember if Deepti is going to present your slides or what.
Deepti, yeah, Deepti is going to present my slides. And Deepti, I hope you're ready because we're going to go through a bunch of slides really quickly.
Yes.
Okay.
All right, so let's do it.
Karen will probably have to correct me, but she is the executive director of the Free Software Conservancy, and I'm told has a long-standing interest in open source medical devices. So as we begin this session, I'd like to just thank all the attendees for staying here. This has been, for me, kind of a breathless 3 hours. We're getting to the end here. We're maybe pivoting to talking about the future. I really appreciate all 112 of you paying attention during this period of time. We're going to hear from Ms. Sandler and then Dale Doherty of Make Magazine, and then Deepti and I will just very shortly close the conference. Thank you.
Great, and I want to start out by thanking you, Robert and Deepti, for this fantastic conference and all of the other speakers. The work that you're all doing is incredibly inspiring. So I'm going to give you a very quick introduction to who I am and why I care about free and open source software on medical devices. So we can go to the next slide. So I come at this as a former developer engineer turned lawyer. Turned executive director, but all informed because I'm a patient. I have hypertrophic cardiomyopathy, which means that my heart is 3 times as thick as a normal person's heart. Next slide, Deepti. But which is fine. I'm generally asymptomatic, but I'm at a very high risk of sudden death. And so, next slide. I have a defibrillator implanted in my body, and that basically has changed the way that I view technology. I like to describe myself as a cyborg and think about the positive aspects of having this implanted into my body. Next slide. Going through that process of getting my defibrillator, I decided to launch a research process into the safety and efficacy of these devices, including FDA approval and the safety of the devices that were on the market, and was a little bit horrified by what I learned with all of the failures. The Software Engineering Institute estimates that there's about 1 bug introduced for every 100 lines of code. So you could do the next slide. And so this took me from the medical device space to all of the other critical areas of our technology. So looking at everything through the lens of not being able to see the software in my own body, which was extremely terrifying and upsetting, especially as a technical person, and to feel helpless and out of control over the basic technology that I rely on, to sort of seeing its societal implications. And this is a study that was published showing vulnerabilities in cars. And I like this slide because the car thinks that it's going at 140 miles per hour, but it also thinks it's in park. The average luxury car has about 100 million lines of code, and so that could be about 1 million defects. Next slide, please. Thanks, Deepti. So all of this caused me to say, oh my gosh, I don't want to use any software I can't see. So I probably went as radical as they come, and I stopped using proprietary software basically at all, which is extremely hard to do. And now I make only very brief exceptions like this use of Zoom in order to be able to speak to all of you good people. So I worked on the Software Freedom Conservancy and other free and open source software initiatives to make sure that we had alternatives to proprietary software and that we could solve these problems in a large and holistic way. So next slide, please. I was really convinced everything was all about transparency and openness. I hear a lot of discussions here about, third-party review and the fact that we need to have transparency and openness in order to solve important questions. For me, I thought that was the entire story. And then when I was pregnant, I my heart palpitated, which is perfectly normal, as many of you know who are medical professionals. And my defibrillator shocked me because my heart, it thought, was in a dangerous rhythm. And the only solution to this problem was for me to take beta blockers, which slowed my heart rate down so much so that I had trouble walking up a flight of stairs. So all of this made me realize that, hold on, wait a second, only 15% of defibrillators go to people under the age of 65. My defibrillator, I'm just not the typical use case scenario, because the device manufacturers definitely do not want pregnant ladies getting shocked, right? So it went for me from being free and open source software, I realized at that moment, became as much about control over your device as it became about transparency. It's not just about being able to see it; it's about also being able to make changes on it. I had no ability to evaluate what my device was doing, let alone work with my medical professionals to adjust that for my case, let alone work collectively with all of the medical device professionals. And the entire community of pregnant women or other people who had interest in the same medical device. So next slide, please, Deepti. So all of this is to say, you've been hearing all day about open source ventilator solutions and all sorts of other great initiatives that are happening in this space. I think that we're at the point where I think something like a third of all software, probably more at this point, is free and open source software. It feels inevitable, right? Like, we know that we'll only have security if we have free and open source software. We know that we'll only be able to get to the market. As Sarah was saying, if we use free and open source software, we'll only be able to move quickly as we need to in these urgent situations, right? Next slide, please, Deepti. So there are all these reasons why free and open source software is going to be, has been incorporated into everything and is becoming more and more standard. And companies, as Marta was saying, are less afraid of it, that they no longer need to rely on those monopolistic IP solutions. But does it necessarily help us build a better future? When you're using open technology in the way that you all are to create on the ground quick medical solutions that are going to save people's lives, obviously that is definitely going to be the case. I think, but we're seeing a lot of free and open source software that is being distributed by companies for motives that are other than making the world better, and that's fine. There's room for all different kinds of motives, and we come together and we find our collaborators where they come, and we work together to do something together. I think that there are ways in which free and open source software helps move forward in a way that actually brings us appreciable freedom that can control our devices and our technology. And never has that been more important than in the medical space. So next slide, Deepti, please. The details on how this is implemented matter a lot in terms of whether or not the solutions are going to make a difference in a positive way. So next slide. I realize I am running out of time. I want to use this example of the Puritan Bennett 560, which was released by Medtronic. Super great of medical device manufacturers to make their designs available in a crisis. That is fantastic. And they released that, they released their designs and their, but they released their stuff under a permissive license only for the time of COVID. So next slide. And so that's interesting because it's time limited. We can only use that right now. Now that is incredibly helpful right now. But it only is helpful to some extent. I'm using this example. This was in the news back in March, where 3D there were valves that were being 3D printed to be able to repair ventilators in Italy, and this made news because at first people had thought that the original manufacturer was preventing the 3D printing by exerting its patent models, but its patent rights. But in fact, they weren't, and they said probably because there was so much press about it, they said no, you're okay to use it because we're in a pandemic and it's okay. Next slide, please. But the question is like, who decides when we're in this crisis, and when will they decide that it ends? My heart situation is incredibly important to me, And this situation that we have now is going to last for a long time, and it's going to be different in different geographic areas. How we deal with this situation as it develops in different places is going to make a huge difference. And relying on the largesse of manufacturers to grant temporary solutions is only a temporary solution for our problems. We have to think bigger picture about our medical care and our medical technology and how we can solve that for the long term. So next slide, please. One way that we can really pay attention to this is by paying attention to the details in licensing. There are differences into how we handle licensing, and I have so little time, next slide, that I would be remiss if I didn't actually talk about copyleft. People don't like delving into, so yeah, this is the copyleft slide because it's a copyright symbol flipped on its side. People don't like paying attention to details like like the copyright licensing because it can be very boring, but it's incredibly important. Copyleft is this idea that that you can take take your monopolistic control over copyright, but instead of using it to issue royalties and to keep control over it, you use those copyrights in order to keep it free. So a copyleft license says you can do whatever you want with this, but if you do use this and distribute the change, if you make changes and distribute those changes, you must do so under the same license. So detractors used to call it viral. It's like a snowballing effect to freedom. Copyleft is a really powerful tool because it is a real it's a real field leveler. It means that if people are using copyleft licenses for their medical devices, that means that when they're distributed, they have to be distributed along with an offer for source or the source. So that source is available, which means that if you need to use that software elsewhere, you can request the source. Under the GPL, the most popular copyleft license, there are a couple of them, but under the GPL, the license also requires that the source not only come with the complete and corresponding source code, but also the scripts to control installation, which means that you can replace the software, which is the most important thing, perhaps. Next slide, and I'll wrap it up. So we need to invest in our long-term healthcare stability. It can't be about this crisis. Now, Robert, you talked about taking plans and mothballing them for the next pandemic. We're in a situation where all of the technology that we're creating now may or may not be useful in the future. We don't know what we're going to need in the future. What we know is that we don't know what we don't know, right? Like we thought that invasive ventilators were going to be the whole thing when we started out. And it turned out that, we have other needs now. And this is going to be the case with all of our technology. So we need to plan for being able to change. And the way to be able to plan is to license everything freely, especially under copyleft wherever possible. Next slide. And I think it's my last slide. Oh, just one quick thing, which is that think about the resources we are putting into Zoom right now. Every conference that uses Zoom, every university that uses Zoom is paying royalties to a proprietary software company so that they can have more of the market share. If we take this time and invest in solutions that may not be as good or as turnkey, and we have a little bit of inconvenience now, we'll be able to have a situation down the road where we have control over our basic technology that we rely on. So let's make infrastructure rather than proprietary business models. And the last slide is just for Conservancy. We're also a charity. Thanks very much.
Dale, can I have 5 minutes of your time and ask you to postpone your talk for 5 minutes? Dale, are you with us?
Rob, he's okay with that.
Okay, thank you. So there are a few questions here. This is not the place for a licensing debate. I'd like to point out, I support the GPL. I just took a $20,000 grant that asked me not to use it and to use the MIT license, which I'm going to do under this circumstance, but I support copyleft. An anonymous attendee asked, is CERN, and I assume they mean the CERN open hardware license, good? That is the official helpful recommended one. I certainly have recommended it. I also admit I have not fully read it. Ms. Sandler, do you have an opinion about that?
I mean, I think it's a very helpful license. I think you're right. I think we'd have to go into a long discussion about there's quite a few licenses that we should evaluate. And I won't be on Slack because, again, it's a proprietary platform, but I'm on Freenode, which is an IRC network, and I'm on Pound Conservancy, and I'm happy to talk about licenses in depth.
Okay, thank you. If we can boil this down to one thing, if you are an engineering team, you need to do licensing, right? There may be some questions about which license you choose, but if you're not putting a license on your work, you are probably making a mistake and limiting the usefulness to other people by not choosing a licensing strategy.
Definitely. By not putting a license on your work, you're basically saying all rights reserved, and you introduce a lot of uncertainty, and your solutions will be very limited in terms of how far they can go, because who is going to pick up a solution that they don't know whether they're going to get sued on down the road?
Okay, thank you. And I know, as someone who codes, I sometimes don't put the license on there when I first start writing the code, but I should. And every one of us who has a GitHub repository, go through, find all your things, put a license on there, just take a little extra time to make that happen. And I've started using Creative Commons for my graphics. I make a lot of graphics, and I just stick it down there in the corner. Okay, Dale, are you ready, sir?
Yes, I am. Can you hear me?
Go ahead. Okay.
Do you want to share my slides? So, I'll try to be pretty quick here. I first of all appreciate everything Robert's doing in this conference, but what I've tried to focus through Make Magazine and what I do with Maker Faire is the maker community and how they've kind of risen to the challenge here. And I've just tried to tell stories about what they're doing. I end up calling it Plan C, the idea that industry was Plan A. Government was Plan A, industry was Plan B, and when neither of those are reliable, you need a Plan C, a backup plan for the backup plan. And it involved, Deepti, are you able to share my slide? There you go. Go on to the next, if you would. And so, I've been writing about how makers have responded, and I've seen this as not just the maker community, but a model for civic response, that people actually want to contribute, they want to get involved. And some people say, oh, well, it's medical devices, they can't get involved. But, the masks are a great example of that. Could you go to the next one, please? So, as I began seeing what different people are doing, that we were in a crisis mode, the CDC was saying, medical professionals can use bandanas and scarves, and it seemed like an inadequate solution when others were available. So just, different groups. The man on the left with the scuba mask is a doctor who told me I was a maker before I was a doctor. And so when he learned he wouldn't get PPE in his hospital in Sacramento, he built his own with his son. If you go on to the next one. This is a story of in Chicago. I think it's a really reflective of how makers came together to sort of build face shields, initially building available designs on Prusa, and then beginning to design some of their own. The purple ones in the middle can be stacked like pancakes and on a 3D printer, and they can be made on the bed of a small 3D printer. But to give you an example, the person on the left that says it's holding something with orange glasses, he is a public high school teacher. He's not a designer, but he came up with a flatbed shield that could attach itself. And Jackie is up in the left holding a yellow shield, began to print it in communities in Chicago that were not being attended to, the South Side and the West Side in Chicago. And others, what was interesting to me is they called it liberating 3D printers from universities, because those places were shut down, and museums and libraries, and they began taking them home, and they built a distributed network to make PPE. Next, please. It just shows you sort of a map of where they are and how they covered an area. So they really created their own version of a distributed manufacturing and distribution network. Next. I won't go into this here, but I wrote a piece on challenging, kind of hackathons and design challenges that I think we're not engaging in how the innovation was already happening, but we're trying to maybe create a separate model that benefited them. And I think the main takeaway from this, I was trying to, particular government agencies that were trying to use crowdsourced innovation, is we'd actually like to know more about what their needs are than just have an open call and say there's some small prize at the end. Next. Hygia is a low-cost UVC unit. Akiba on the right-hand corner is in Hacker Farm in Chiba Prefecture in Japan, and he's building UVC units, but he's also building dosimeters to test them, and I think it's a really fascinating project. He was, I think, involved in SafeCast, another maker project after the Fukushima disaster to measure radiation throughout the country. Next. Atlanta, again, just a group of community of different maker spaces networking together. They began injection, silicon molding, using 3D printers to create molds and using silicon rubber to make masks. Next, please. Starvin, I wrote recently, Pat, I believe, is on this call. He's a professor at Full Sail University in Orlando, but a maker that I ran into last year, and he had built his ambu bag type of ventilator. Next, please. In the Montana mass, it's a doctor on the left who, when his hospital told him he would have to reuse masks, he said, that's not a good idea. I'm a neurosurgeon and I get blood all over my mask. I need one for each surgery I do. So he came up with a new mask. But I think part of the story here was not only how it happened in Billings, Montana, of all places, but how it spread around the world. And the woman there, Corey Hawks, really is a volunteer, a wife of a Air Force physician who, through a network of wives of physicians, learned about this. And she said, how can I help? And she built a website, began to expand it, and they open sourced it recently, the mask, and it's really spread around. So I think the next, please. I think I have one more on, this is Artisans Asylum in Somerville, Massachusetts, which is now running 3 shifts a day, making hospital gowns or isolation gowns, which they reverse engineer. They're also making tools for folding surgical masks, 3D printed tools, and even selling those to factories. So I see this as unleashing this power. Many ways, maker spaces are something that, if you go to the next one, have been, we've been building this kind of infrastructure for 10 years, and some people don't even know what it's good for. And a little bit like what Karen was talking about, it's open, it's an open community. Can you go to the next one, please? We started to share, this is the next issue of the magazine, which we're covering on this. I'm calling this sort of countermeasures for COVID-19. I'm really interested in this idea of civic infrastructure. It's not discussed enough, it's not valued enough, and it's obviously we were lucky to have some of this in place, but it's in a fairly rudimentary, under-resourced fashion today. It doesn't fit business models, but I think it's actually a way to think about the future, along with like public invention. How do we solve for problems that don't have upfront business models? The other thing is there's so much competence in people in our country and around the world. And how do we leverage that? What I find so interesting about the helpful engineering and open source medical supplies group is look who's joining them. They're people that have day jobs in big companies, but they're joining these groups because they can make a difference and they can contribute. And there's something missing in government and industry that is not allowing people to contribute to solutions. So that's what we need to build. And just maybe this weekend, Saturday, we have a virtually Maker Fair. Next slide, please. And I've kind of just a fun slide. You might have to click on that deep D to see if it'll work, but it's just it's just the way makers are, to create a mask that promotes the event. So, and if you just go to the next one, so we have about 350 entries of projects and sessions this weekend, all online, just like this. A remarkable job here done by Rob and Deepti and team. And I think the idea is just open this up so we can have more visibility into what's going. When I saw Karine talking about Kenya. It's the same pattern in many, many places. And how do we begin to inform? I guess my role and others is just try to connect these efforts and talk about them so people understand what they're doing, and perhaps people that are not involved with them understand the value of this and begin to support this infrastructure in the community. Thank you, Robert.
Robert, we can't hear you. You're on mute.
Sorry. Thank you very much. Dale, you're being thanked by an anonymous attendee. I don't actually see any questions here. Thank you, everybody. I was very rude to our speakers and forced them to stick to a ridiculous timeline. Hopefully the attendees appreciated getting a lot of information. I'd like to take a few minutes here, and maybe any of the panelists who have a closing thought before I give my own closing thoughts can add something.
If I may.
Go ahead, Dr. Sarah.
So I think that I want to take into account what Karen just mentioned about 3D printing, and also as part of the, let's say, closure of the idea of funding and how we need to, let's say, measure our steps or plan ahead as it relates to, are we thinking a short term, long term? For instance, some of the funding options are 24 months just to obtain, and et cetera, et cetera. So I just want to convey the thought that it's very important to understand that we are in a dynamic, that fast-paced situation, and we need to sometimes be able to maneuver fast enough in order to adjust these circumstances. So just a thought.
Thank you. You know, personally, I'm an agilist from a computer software point of view. I believe in being agile and going fast. I believe Elon Musk and SpaceX have shown the benefit of that even for engineering. It's a challenge to go fast when you're making a life-critical medical device. It's not a challenge that can't be met, but it is a challenge. Does anyone else like to say something?
If I can comment, having said that, we see how the government has reacted, especially due to the COVID-19 crisis, where they've expedited various processes as it relates to drug approval and other, you know, what we call bureaucracies. So that gives us some kind of, let's say, there is a room to set new expectations in the way that we define what is the appropriate, let's say, process of doing things, and maybe rethinking those processes could actually help us move much faster in the long run.
Right. Okay, if no one else
I guess I could
go ahead, Michelle. Oh, Tim.
No,
Tim,
Michelle.
Tim first, then Michelle.
Okay. I just wanted to say that this has been a really amazing conference, and it doesn't have to stop here. I think it's been interesting to hear different perspectives and people disagreeing even among the panelists on focuses and other things. And so I think that keeping in contact with each other is really important. We can do that in the closing resources channel in Slack. And I would encourage everyone to keep active and keep talking, because we don't get through this, you know, with 1 3-hour session. We gotta keep working together.
Thank you, Tim. I'm going to reiterate that in my own talk, but go ahead, Michelle.
I think kind of the one last thing I wanted to close with, and I had some good discussions with people on Slack this morning, is that, you know, I think, you know, we're talking about the need for lower cost solutions and lower cost ventilators in other places. And I think from, you know, the perspective of someone who studied pulmonary biomechanics, I think really the thing I would want to reiterate is identifying safe ventilation is difficult, even when you have the best technology that is available to you. And as you seek out solutions, I think it's important, and Rebecca addressed this in her talk for EWB, which I've been involved with them a little bit as well. And I think, you know, that's really knowing which kinds of treatments are really the most appropriate for your region and what can you implement quickly when it comes to, you know, do you have the drugs to keep people under? Do you have the trained staff? Because it really is easy to use a ventilator in a way that can do more harm than good. And I think everyone here is really interested in doing a lot of good. And so I think I just kind of want to end on that slight note of caution, but also I think really a note of hope.
Okay, anyone else?
Just to finish, Robert.
Marcos, go ahead.
So we are in a very deep humanitarian crisis worldwide. The problems are infinite. And the ways of approaching these infinite problems are also infinite. We have to think outside the box, totally outside the box. The system that has took us for the last 400 years didn't work. We are like drowning ourselves on a virus, on the micro scale, on the nano scale, to the macro scale of the economies. We have to think on a chaotic way of solving problems. I like to remember when NASA developed a pen that could write on space and invested $100 million on that, while Russians prefer to use a pencil. So there are several ways to solve problems. And I think that communication is essential. Dialogue between people that think different is essential. We have to change everything in the system, not only the health system and the manufacturing system, but the validation system, the regulatory system, the funding system. We have to solve that in a global way of thinking, because we are now a global village. We are all people speaking from 5 different continents, trying to solve a problem worldwide that we don't even know where to start walking, but we know where we don't want to go walking. We don't want to go walking on a proprietary way. We don't want to go walking on an exclusive and differential way. I think all people here are working on that. I really am grateful for being side by side to you, working this every day. And I let my contacts open for anyone willing to help also on third world countries.
Thank you very much. I'd like to read a comment from Govind Tadachari. Amazing conference. Thank you all. The pandemic affects everyone, and we need to encourage everyone to help contribute in their own way. I absolutely agree with that. Let me take a few minutes before I begin our very short closing presentation to just review what we have had. As Marcos said, maybe it's a little purple, but I don't think so. We're doing something that has never been done before. As a planet, we are addressing a crisis which has never existed before, and we're using tools that were not available to people before to address these problems. We're working in very difficult circumstances in a presence of tremendous uncertainty, financial uncertainty, even medical uncertainty, transportational, supply chain uncertainty, and yet we are working to solve the problem. As Dr. Griffer said from NIST, we have a further problem that there may be a surplus of sophisticated ventilators in the United States by July, which we probably don't have a good way to get to Brazil, Kenya, or Guatemala, for example, which only makes our problem more complicated. Nonetheless, and I suspect many of us, I know I'm tired of being locked down in my home too. And I'm also a little tired of working on ventilators. We don't know for sure how many lives this effort is going to save. I'm not talking about PPE. I know that's going to save lives. I'm talking about ventilators. I don't know when the first patient is going to be saved by a ventilator done by a team on this call. I don't know how many people are going to be saved. It might be zero. I think, you know, we have to be honest and admit that possibility, but it might be 1 million. It might be 3 million for all I know. There's a great deal of uncertainty in the future. So I just want to review some of the things that have happened. I think as a community, we are in the middle of the game. This is, if you play chess, this is the mid game. Some things happened and we have learned some things. We've learned some medical things. We've learned some things about regulation. We've learned some things about financing. We've learned some things about how to work together in a planetary community in a certain way. Dr. Schultz has said we need more power. We've learned we need non-invasive ventilation, which requires more sophisticated ventilators than we started out making. Karen Sandler has poignantly pointed out that we need the freedom to modify the devices, not just to see the code. Why do we need the freedom to modify? Because as Marcos knows, the supply chain is not present in Kenya or Brazil based on what may have been designed in the United States. We also need these kinds of modularity and openness for a number of other reasons. So if no one, let me go into this talk just so we can finish up on time. I'd like to thank everybody who has joined us.
Thank you, Robert and Dipti.
Thank you.
Okay, once again, I'd like to thank everybody, but this conference would not have happened without Deepti. This is just my opinion, but I think many of the speakers here have added evidence to my opinion that there are certain principles we as a community can work towards which are useful. The first is flexibility of treatment. It is not the role of an engineer to tell a doctor how to treat a patient. It is the role of us to give as many tools to the doctors as we can. What we don't want is for a doctor to reach into a toolbox and find there is no tool available, right? We don't know for sure how doctors are going to use ventilators, but we can build the best ventilators that provide flexibility of treatment that we can, and we can make them available not just in the wealthiest nations, but in the other places where they may be needed, even though we don't know for sure exactly how many are going to be needed. We don't know exactly what features are going to be needed. Therefore, engineering modularity can provide us resilience and an ability to respond to change. Engineering modularity is a challenge in the presence of the way we do authorization of medical devices and making life-critical devices safe. But it's a challenge that we can rise to. Cooperating teams may allow us to get faster to the deployment of a ventilator that saves the first life. Why? Because multiple teams can operate on things. There are probably a few thousand highly skilled biomedical, electrical, and mechanical engineers working at least part-time on this problem, and probably a dozen working full-time on the problem of providing ventilators. That is an enormous amount of intellectual power. If we can correctly utilize it, we may actually be able to go faster. Okay. However, as Sarah Benson Conforti pointed out, you have to communicate more. The larger your team is, the more the burden of your investment in communication and cooperation becomes. From an engineering point of view, softening, by which we mean using software, making the components smarter around standards allows greater versatility. And then finally, in a way that Karen Sandler pointed out, openness leads to confidence. We need to give, as Karina Malul said, there are some doctors in Kenya who are never going to use a rapidly manufactured ventilation system. Okay. Why is that? Because they don't have confidence in it. How do we make that happen? How do we give them that confidence? I believe it's some combination of going through all of the tedious steps that Michelle Lott pointed out, which are, they're something that can be done. They're difficult, but they can be done, combined with third-party testing, which is something that the open source software community understands and has maybe led the way on in a way that up to this point, maybe the medical community has not. So I believe openness provides transparency at an engineering level, which eventually will lead to greater safety. Okay, those are just opinions, but as a community, we may be able to work these things out. Okay, so what would we do if all 10,000 of us, there may not be 10,000 biomedical engineers, but if we count people like Sarah and Narayan and Jokai and Martha, who are philanthropists and investors, if we count the people working on finance and health professionals and engineers and other people, there are probably 10,000 working on the ventilator problem. How would we behave if we treated ourselves as one team? Well, we would not have 100 independent ventilator projects. Rather, we would break up the problem into modules. We wouldn't have just one team on each module. We might have 5 teams or 10 teams, because redundancy is good, but we wouldn't have 100 teams on any one module. And DP and I created this Trello board to sort of represent our initial stab at how this would be done. This is just an idea at this point, right? But we would separate software solutions from hardware solutions. And how do you separate those things? You have to have standards. You have to have published, documented standards that allow that to happen. We would even separate quality assurance. How do you separate quality assurance? You allow third parties to do testing of your equipment, okay? We would create finance teams that would be separated from the engineering team. Separated is not really the right word. They'd be connected to the engineering team, but we would create people dedicated to getting large donor commitments. We would create people dedicated to production cost planning and raising money for actual production, because going from a prototype to production, you tend to move from approximately $10,000 to approximately $10 million. There are other things that we could do. You, as Dr. Griffer pointed out, you also have to talk about transport. You have to talk about sanitation, reuse, recycling, triage, a number of those things. But these are problems which we can solve working together. So DP, would you like to have the final word here and talk about resources that we have put together to to continue the conversation which has been started by this conference?
Sounds good. So the first thing, I want to remind everybody to join the Slack channel, because a lot of our speakers have graciously offered to answer questions on that, not just today, but continuously. So that would be a phenomenal way to continue the conversation. I want to plug the Maker Faire one more time. It's happening this weekend. It's an amazing event. Please attend, and it's going to be very inspiring. Dr. Joshua Pierce from Michigan Technology University has graciously offered to do third-party testing for any open source ventilator efforts. So we'll make his information available. We have a list of funding sources. Just this one link has about $1 trillion in grants and 550 unique organizations. So please check that out. The Trello board that Dr. Reed just mentioned, you can use it in 2 ways. One, you can be part of the community that helps us build this modular ventilator, and we'll send out the link. Please sign up. The other way you could use it is that you could offer components that you have already developed as part of your ventilators to this modular Trello board, or take from it if you think that component that you have, the design of which could be improved. What we're going to do is so much good information has been generated that we're going to be keeping a Google Docs. I know Slack may not be accessible to all of you, but we'll try to link all the resources that we talk about in the Google Docs, but we're really requesting in the spirit of collaboration that you share your lessons learned, resources that you found useful, so the entire community can benefit from it. And together, we can solve this a lot faster than if we work in silos. Dr. Reed mentioned there are about 100 other ventilator efforts. We have put a link in there to that spreadsheet that will link to their websites. So that should help with the conversation. We're going to be recording this entire conference, and we'll make the link to this available on a YouTube channel, so that will be available to you. And then we talked a lot about social entrepreneurship in the developing world, and we have some resources for you on that topic as well. So thank you all for joining us, and my gratitude for all the work that you're doing to save us in a time of crisis like this. Back to you, Dr. Reed.
That's it. Thanks. Signing off. We will be trying to post recordings and other documentation coming out of this. Please keep the conversation going.
Thank you.
Thank you very much to everyone. It's been a pleasure.
Thank you very much.
Thank you. Stopping the recording now.
Thanks, everyone.